Navya?
Yes, ma'am.
Hello.
Hello, everyone. Rajeshri, Dr. Chitra.
Good evening, ma'am.
Nice. Good evening.
Good evening.
Good evening. Yes. I was
Hi,
not
Dr.
able to
We are just waiting for Dr.
Dr.
Kasturi
Vidya, how
to
are
get
you?
back. She said she'll be joining
I'm fine. I'm fine.
Great. Yes.
So
Navya, you will
don't
be
miss this time,
sharing.
Soga.
You will be sharing biodatas, na?
Yes, sir.
Okay, because see, first time I am doing webinar from labor room. Great.
Rajeshri, I'm really sorry because I'm in undergraduate examination. So I just wish you all the best because I just stopped one student entering. So all the best. I'll join you later after this Viva portion is over. And then concluding remarks, I will join. So all the best for your program. Okay.
All right,
I can see Preeti, Chitra and everyone. So I'll join later. Okay. Thank you very much. Thank you.
All right.
All the best.
Thank you. Thanks for coming. Shall we start, Navya?
Yes, ma'am. Sure, ma'am.
Yeah, I think we can start. Yeah.
Good evening, everyone. Thanks for taking out this generous afternoon of Sunday to spend this time with all of us. So the Lumos webinar is a series of talks that is the brainchild of none other than our beloved Rajeshri Madam. The idea behind Lumos is a magical spell in the world of Harry Potter, which means to spread light. Here we are all here today to spread light on clinically relevant topics for OBGYNs in the field of fetal medicine. And we are joined by none other than Dr. Chitra and Dr. Preeti Madam, who are stalwarts, who are big figures in the field of fetal medicine, who have just started and introduced fetal medicine over the period of 10 to 15 years for all of us. So let us start off with the blessings of the Almighty.
कल्याणं आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणं.
So this webinar series is a plan of 4 sessions where we have tried to break up into different sessions depending on the gestational age, starting from the first trimester, going through the transition of the mid trimester, covering growth, including the medico-legal aspects as related to fetal medicine. I would like to welcome you all for this series, which is a brainchild of none other than our Rajeshri Palade Madam, who needs no introduction to this crowd. She is a busy practitioner from Gulbarga and heads the Aditya Multi-Speciality Hospital. Apart from being busy in her clinical practice, she is generous enough to take out time for every academic activities, and my association with her dates back to 2 years back, where she accepted me to be a secretary for the Society of Karnataka Genetics and Fetal Medicine Society, and she has been the chairperson and conducted many successful webinars, including one offline session in Bagalkot, which was a huge success. And following that, since 4-5 months, madam said this term of Kasoga Genetics and Fetal Medicine Committee is incomplete till we consolidate all the concepts of fetal medicine and put a consolidated series in front of OGCians with the inputs of excellent fetal medicine specialists, so that basically we have a report of ultrasound in our hand. How do we convey the report and take decisions for the best possible benefit of the patient? So we are here with the webinar series. Madam is the executive committee member of the Kasoga 2013 North Zone. She has been the organizing secretary of the 25th Kasoga State Conference held in 2014. She has been a faculty for various national and international conferences. She is a very beloved and energetic speaker. I hand over the dais for her. Madam, please start off with an introduction of our webinar series, and I would like you to welcome our chief guest. Madam, is it okay if I share your slides?
Yes, please. First of all,
Sorry, ma'am, your voice is not audible, ma'am.
Warm welcome to
breaking,
this
ma'am.
series of webinar on different aspect of clinical practice, and we see. Am I audible now?
Yes, ma'am. Now it is better. We lost you for the last 30 seconds, ma'am. Can you please start off again?
All right. Pranamam, everybody. A warm welcome on this Sunday afternoon, who have all logged in to be a part of this deliberation of an important topic of genetic and fetal medicine, which has evolved a lot in the past decade. And we see that a lot needs to be understood more so far as the interpretation, reporting, and detection of anomalies of the fetus is concerned. So a lot of thought process was put into this. Initially, we thought that we'll make a live interactive session, physical, but due to some logistic issues, this was not possible. And we now have a series of webinar designed so that each topic trimester-wise can be picked up and discussed in more details. Always the seekers for knowledge find it very, very feasible to attend on to the programs, come what the challenges are. And for this particular session, we had two lead people, Dr. Chitra Ganesh and Dr. Preeti Venkatesh, who have been very interactive, very cooperative, and very, very supportive so far as the designing of the program is concerned. And we had a lot of deliberations collectively to think as to what could be the best program that we can deliver to the audience. With the support of Kasoga, our dear patron, MG Hiramat sir, who has been very, very supportive for all our committee programs and who has been a leader and throwing light. The day he called me and said, maybe you can do a session in fetal medicine, I was very doubtful about myself, whether I would be able to deal with this topic, which is very, very new and not much understanding is there so far as the scenarios are concerned. And then I thought maybe this will be a learning experience for me as well. And I'm very, very grateful to Dr. MG Ramat sir that he has thought of so many committees in Kasogas, and each of the committees we try to come up and try to collect knowledge and try to collect the best of the faculty in the regarding subjects. And here we are on this Sunday afternoon, in spite of having a heavy meal, and then most of us would like to relax, but then we are here to listen to more about what the experts have to say. I'm very, very grateful to Dr. Kasturi Donimat Madam, our beloved president in Kasoga, who has always been very supportive and encouraging. And anytime when I called her, I said, Madam, we would like to do this program, such and such program. She said, anytime you do, we are always there. So also I am grateful to the executive members of the Kasoga, Dr. Bharti Rajshekhar, dear secretary, and treasurer, Dr. Durgadas Asrana, who always tries to be attentive and always attends all of the programs, come what time of the day it is, either in the afternoon or in the evening. He's there to support the programs of the Kasogas all through. I'm extremely grateful to the best of the faculty that we have today, Dr. Chitra Ganesh, Dr. Preeti Venkatesh, and Dr. Malini, who have agreed to be present on this occasion, and Dr. Milind Arsha, who happens to be from our adjacent place, Solapur, and very active in a perinatology committee. And he has represented at national and international levels, and he has gracefully accepted to chair this session. And so also Dr. Malini and our dear friend Vinuta from GeneTech, who is an expert and who have been doing a great work in field of genetics and fetal medicine since many decades. And theirs happen to be a landmark institute in Hyderabad. So here we are, dear friends and faculty, seniors, respected members, and the executive members of Kasoga, which we are very grateful for giving a platform to share and be a part of this interactive session. And Luminos, as very rightly thought by Navya, she's been very dynamic, active, and I'm glad that she came up and doing a very justified service in field of fetal medicine. It was her terminology. She said, Madam, we'll call this as Luminos because we are trying to throw light upon many untouched topics, like as it is in the Harry Potter series, they say Luminos for some problems. So here we are with the Luminos series. And now I request Dr. Kasturi Donimat ma'am to please address this gathering. Kasturi ma'am? No, ma'am, you're not audible.
No? Yeah.
Yes, yes.
Yeah.
Yes, you're audible now.
A pleasant evening to one and all. Namaste. I bring greetings from our Kasoga family. Today it's really a great day. I first of all would like to congratulate Dr. Rajeshri Paladi and Dr. Navya for bringing up this such a important series. And what a name, Lumos. I was thinking why they have kept Lumos this name. So very interesting to know that, like, it is like enlightening the mind. So very interesting name also. And I hope under this series you carry on like lots of activities and educate and transfer the skill to all of our Kasogians. And today, very important topic also, that is first trimester essentials with basics of genetics. Each and every obstetrician, when a first trimester ultrasound a patient comes with the report, or when you are doing, there are lots of like this way, that way, like where to go about, because any risk we always tell this much is the risk, or this much is there is no risk, or 98% it's fine, 2% still risk. So many times that question mark uncertainty is there in the mind of obstetrician. And this webinar series is going to clear so many doubts and myths or anything up from the obstetrician's mind, and it may going to make easy practice to for counseling to all the patients. And I'm thankful to our chief patron, Dr. M.J. Ramat sir, patron, Dr. Nagraj sir, and our secretary, Bharti Rajshekhar, treasurer, Durgadas, and all the EC members, and our next incoming president, Dr. Vidyathabi, for all being there for this program and making it a grand success. My very special thanks to the main resource persons today, Dr. Chitra Ganesh and Dr. Preeti Venkatesh. All the gynecologists are always very eager to learn from you. I know many people have joined this webinar. Everybody is eager to hear from you the pearls of wisdom. Who other than you two can take up this important topic? Even I am very eager to learn. I always look up to your lectures. Whenever is there, I somehow see to it that I take out time and join and learn from you all. And also thankful for chairpersons, Dr. Malini and Dr. Milinsha, for accepting the invitation from Kasoga. And Dr. Milinsha, sir, in spite of his busy schedule from our neighborhood, has accepted. Thank you, sir, for being there. And I once again thank and congratulate Dr. Rajeshwari and Dr. Navya for taking up this very important series. Without wasting much time, I think we'll go ahead with the subject proper. Thank you for everyone for accepting and for being there. Thank you everyone. Yeah.
Thank you, ma'am. I also take this opportunity to thank Dr. Vidya Thubi, ma'am, who has been the advisory board for the Fetal Medicine Committee and who was just there a few minutes before we all could join in. She is busy conducting an exam in Bijapur and she has conveyed her best wishes for the program. Thank you, Vidya, ma'am, for joining and giving us your wishes. Over to you, Navya.
With that, I would like to introduce our chairpersons, Dr. Milind Shah, who is a busy practitioner from Solapur. He heads the Naval Maternity and Nursing Home in Solapur. He is an expert in obstetrics as well as infertility. He has been the past president for various societies and he's the present serving president for the ISO PRB. That is between 2016 to 18. He has been the secretary and president to various national bodies. You can see that he is a national and renowned national and international speaker. He has been the editor for various journals in India and abroad. He is the past president of Solapur OG Society. He is the professor and HOD in the Department of OBGYN in Gandhi Medical College in Solapur. He has authored several chapters for and contributed several chapters for several standard books. Thank you so much, sir, for being here. We are honored to have you here and we are looking forward for your inputs.
Sure, thank you.
Next, we have Dr. Malini from the Fernandez Hospital, Hyderabad. We can see that she is a mix of an expert OBGYN with excellent knowledge of perinatology and ultrasound. We could not have asked for a better chairperson. She has special interest in all medical diseases related to obstetrics, such as the heart disease in pregnancy. We know that Fernandez Hospital is famous all over India for its expertise in management of high-risk pregnancies as well as medical disorders in obstetrics, and it has opened a unique branch. It was the first one to introduce this concept of maternal fetal medicine. We are so lucky to have you here, madam, and I hope you will be throwing light on how you see this collaboration between maternal fetal medicine and you're actually practicing it. You are the best person we could have seen as a chairperson for the talk. Welcome, madam.
Thank you so much, Navya, for the kind introduction.
Can we go to the session now?
Can we start the session now?
Over to you, Milind sir, to please. Yes, sir.
Thank you very much. It was indeed a pleasure. In fact, there is some problem with my camera which goes on and off. Maybe I'm in labor room and that's why, but fortunately, I have some time to start the webinar and maybe in between I will have to disappear for a few minutes. But I'm of course eager to listen from you all and learn as well, as everyone said earlier, because it's always a pleasure. You know, friends, Kasoga is very close to my heart because I stay quite close to Karnataka. Nanaga Kannada matadlik bartaite, and I can read and write Kannada as well. And that's why, but I never dare to speak in front of Bengaluru people because that Kannada is different than what we speak at Sholapur. But I always enjoy interacting with my all Kannadiga friends. And that's why, Dr. Kasturi, I still remember you had called me for Hubli program. I could not travel because of AMOX overlapping.
Yes,
but today I am very much with you to understand about this first trimester and the other actually problems related to fetal medicine and genetics. I must say big thanks to Dr. Hiremat as well, who was very much with me active in the Foxy or various posts. Also to Secretary Bharati, who had been actually a very close friend and had been to Hassan so many times. And Durga Das as a treasurer, yes, he had been to my center as well to learn infertility long, long back. And when I see him at this position, I really feel very happy. Rajashree is one of my very close friends since last 30 years. Being very much near actually Sholapur and Gulbarga, we always keep on interacting with each other, and more so our patients do that in very, very good way. I'm also happy to meet all these friends, Navya, Preeti, Malini, and all those, because I've been interacting with them since many years whenever I used to travel to their respective societies. Now, coming to this committee actually of the fetal medicine, which has been started in the Kasoga, definitely carries a lot of actual weightage as well. Because nowadays we have understood that there are so many advances in the fetal medicine. Gone are the days where the anomalies are detected at the time of delivery, and quite often we are now able to diagnose not only aneuploidies but rare and rare anomalies at the very early stages of pregnancy. Additionally, the genetics has put more actually the scope for implementing in the practice, because all these laboratories have come to our doorstep, and we can definitely do wonderful actually the investigations to find out what actually is the responsible allele which is there in that particular couple. In Karnataka, I always find patients coming from Bijapur, Gulbarga, who have a lot of actually the prevalence of consanguinity. And that's why it gave me wonderful actually the cases, very rare anomalies which we could diagnose, could do a lot of workup, and that those cases were presented at the various platforms, gave a lot of applause actually from various actually people. Friends, nowadays the DNA storage has created a major actually the outbreak in the field of fetal medicine, and which is available in each and every city now, whereby the patient gets breathing time before he or she thinks about doing further investigations. But our obstetrician friends must try to contact those laboratories, which is very, very cheaper intervention, whereby we can definitely store the DNA of that particular fetus whom actually you abort or who has come with stillbirth, and we can definitely do workup in the couple to find that particular responsible gene. And all that is possible actually very easily in the cost of hardly 2000 or 3000 rupees. So with this, let us start with the this academic feast, which I am also going to enjoy today. And first talk again, very important, ready for the challenges in the early pregnancy by none other than the Secretary of Fetal Medicine Committee, Dr. Navya. She had put in a lot of sweat for this particular webinar. I could understand as I was communicating with her and Rajashree since last few days. And definitely it is going to add a more knowledge as well for all those delegates who are logged in for this particular webinar. First, actually, the early pregnancy or the first trimester pregnancy always and always carries so many actually problems. Yolk sacs sometimes smaller or larger, liquor slightly here and there. Sometimes the fetal bradycardia also we notice. So many actually things, so many issues. And suppose you find that the fetal anatomy is not as per expectation, naturally we need to think a lot about that. More so, the irregularity actually of the menses we must need to consider, because I have witnessed quite often the women they forget last menstrual period. They tell something and the clinicians think that the sac is not sane and probably it is ectopic, and they start intervening. No, we'll have to wait a lot. We'll have to see that it could be an intrauterine pregnancy and patient may be wrong in telling the date. And that actually the message need to be given to all our delegates who have logged in today for this wonderful webinar. Can I have the CV of Dr. Navya?
We have Dr. Hiramat sir, who has logged in from another
Yes.
link, and
Correct.
wishes for the program, and
Yes,
there with us all through.
correct. Yeah.
Sir,
So, Dr. Hiramat want to speak first, and then I should introduce Navya.
Sir, he is not able to connect through the link, sir.
Not
I
able
think,
to connect. I think I can introduce Navya so that we can start
yeah.
with the talk, and in
Yes,
between he can come to join the webinar.
yes,
Now,
sir.
Dr. Navya, actually, first I must apologize, Navya, that I was asking her whether you're a consultant or the PG student, because her voice was so sweet. and so young. So I thought she's a PG student. And then when I realized she's such a wonderful actually practitioner, I was really very, very happy. She's working as a fetal-maternal medicine specialist at Rainbow Children Hospital, Bengaluru. And her area of interest is obstetric medicine, fetal medicine, and genetics. She's UK certified by Fetal Medicine Foundation for the fetal anomaly as well as the NT-scan. And she's secretary of this Kasoga's Committee of Genetics and Fetal Medicine. I'm very sure, Navya, you are going to bring a lot of awareness amongst your all Kasoga friends, which is going to create a lot of change in their practice as well, and the patients are going to get benefited as well. She's also a member of this study medic, that is a NEET, which is for the MD and MS examination. And with this, I think, Navya, we are eager to listen from you, the light which you are going to put in on these challenges of the early pregnancy scan. The stage is yours, Navya. Please start with your talk.
Thank you so much, sir. Even without seeing my slides, you have already summarized whatever I have already put in my slides. That is really magical. So this talk is slightly different from the rest of the talk in the series because we have tried to convey the counseling part in the rest of the planned programs. But we know that obstetricians are excellent in transvaginal ultrasound and manage most of their early pregnancy scans by themselves. So my talk is very brief, and just for the completion's sake, I have just added the first trimester, whatever the regular important aspects are there, and where we can improvise on our transvaginal scan skills as relevant to early trimester. I hope my screen is visible. No.
Yeah, it's visible now, Navya. You can start. Yeah.
So just 3 topics, what I'm going to summarize. Has Sir said, first trimester, sonoembryology, what are the landmarks of the first trimester to assess whether it is a viable, or when do we call it has a non-viable pregnancy. Ectopic pregnancies, routinely, yeah, we are able to catch when there are huge hematomas. Are there some clues early on in ectopic pregnancies which will help us to polish our skills so that we can suspect them early? Then lastly, there is a lot of confusion when it comes to the interpretation of retained products of conception. How much of products is significant? How thick endometrium will need intervention? So some data I have put together. We will see whether it will be useful for us to make some clinical decisions. So starting off, the first sign of the pregnancy is the nice hyperechoic ring embedded within the endometrium, away from that midline of the endometrial cavity with a hyperechoic line, which is known as the intradecidual sign of our bright gestational sac. It is very important that we distinguish between this true sac and pseudo sac, which is relatively collapsed. The pseudosac is mainly formed because of some fluid collection within the endometrial cavity. Many times when there is ectopic pregnancy, you might see this misleading pseudosac within the endometrial cavity. So we should be sure to catch this intradecidual sign so that we will not miss our ectopic pregnancies. But remember that the early gestational sac is not a sure sign of intrauterine pregnancy. You better wait till there is an appearance of the yolk sac, which is an eccentric, regular, small circle within the gestational sac, which is the only one which is going to confirm our intrauterine pregnancy. Next appears the diamond in the yolk sac, which is nothing but the fetal pole as early as 6 weeks of gestation. This is followed by almost when the CRL is as small as 2 mm, we can start noticing the fetal heart rate. But how much of this fetal heart rate is normal? There are studies that say that anywhere between above 90 might be a good heart rate to have in very early pregnancies. Below 90, we might have to keep it in the area of pregnancy of unknown viability, and these are the pregnancies that might need a follow-up in 2 weeks' time. Next comes the amniotic sac, which is a small membranous structure that starts covering the embryo around 7 to 8 weeks' time. Usually it is tightly embedded around the embryo and it is relatively smaller to the yolk sac. So these are the signs of viable pregnancy. So when do we call a pregnancy as non-viable? There are two size-based criteria, two time-based criteria. One is that our fetal pole or CRL, if it is more than 7 mm and there is no heart rate, then it is mostly a non-viable pregnancy. Or you measure the gestational sac, it is big enough. Means the mean gestational sac 3 diameters is 25 mm and you're not seeing any embryos, then mostly it is a non-viable pregnancy. What are the time-based criteria? There has been 2 weeks since you saw your gestational sac and yolk sac is not yet visible. Then most likely it is a non-viable pregnancy. Or more than 11 days after both the G-sac and the yolk sac is visible and your fetal pole is not yet visible with the heartbeat, then mostly it is a non-viable pregnancy. But RCOG always wants that before you call on a pregnancy as non-viable, confirm from 2 operators either on the same day, or if it is the same operator, take a week's time and repeat the scan in a week's time and see if it is really non-viable. Also, there is some criteria where we which is intermediate between viable and non-viable, where we can counsel the patients that there is chances that the pregnancy can go either way. That is, when the CRL is less than 7 mm, no heart rate. But because almost when the fetal pole is visible, you are supposed to see the heartbeat, though you might not be able to record it over your regular ultrasound. Or when the mean gestational sac is between 16 to 25 mm and there is no signs of the embryo, or it has been 7 to 13 days after the G-sacs and the yolk sac is seen. All these time-based and measurement-based criteria help us to time when we want to recheck on this patient, because we don't want to call very frequently back so that we will cause undue panic, anxiety, and we will not be able to give an answer for sure yes or no. So it is suggested that we should, when there is something like this, we should wait for around 7 to 10 days before we call back the patient for a re-evaluation. Also, there are certain signs on the ultrasound which can indicate poor prognostic features. Maybe we can use these poor prognostic features to decide which patient might require a rescan in some time after their initial early pregnancy scan. When you seem to see a very large yolk sac that is more than 7 mm, or a calcified yolk sac, or a very irregular gestational sac. Sir was telling about first trimester oligohydramnios. Is there such a criteria? Of course it is there. Means when the mean sac diameter minus the CRL is less than 5 mm, means you feel that the gestational sac is relatively small compared to the CRL, then you might have to recall this patient to confirm its viability. Something that is known as an empty amnion sign. I told you that when almost after the fetus appears, the amniotic sac is supposed to be seen clearly. But sometimes what happens, the fetus is still small, but you see that the amniotic sac is growing and it is looking more prominent than the yolk sac. This is known as the empty amnion sac, again a poor prognostic feature. Or the amniotic sac is either the fetal pole is absent or the amniotic sac is very big compared to the yolk sac and the fetal pole, then it is known as an expanded amnion. Also, I said fetal bradycardia, that when the initial heart rate when you record, if it is less than 85, then again it is a pregnancy of doubtful viability. When there is subchorionic hematoma. So first of all, we should make sure that we don't call a false positive subchorionic hematoma, because it is going to cause undue panic for the patient. The doctors might have to take the decision if they want to add on lot of early pregnancy supports. So when the subchorionic hematoma covers more than 50% of the gestational sac, it is supposed to be more significant, and this is the pregnancies which we need to watch out for. So first of all, the important thing in about viability is we should never make a misdiagnosis of miscarriage is unacceptable. We might take some time, we might it might cause some discomfort to the patient, but however, we should give the benefit of doubt to the baby, and if it is going to survive, we have to give some time before we call off it has a non-viable pregnancy, because always first do no harm. Ectopic pregnancy, I'm sure most of you might be detecting ectopic pregnancy. Let us see if there are some special clues about ectopic. Over the past 3 years, I was really lucky that I could work in infertility, very well established infertility unit, where I could see all type of complicated early pregnancies. This is the summary of what I think is the trick to diagnose early ectopic pregnancies early. First thing, always know the history. Was it a spontaneous conception or assisted conception? If it was an assisted conception, again, dig deep whether it was induced for ovulation, with what it was induced. And if you have the access to previous follicular scans, just check out how many follicles, dominant follicles, was the patient getting. Were you expecting 1 pregnancy, 2 pregnancy, or there were many follicles, and unfortunately still the patient went ahead and tried for a pregnancy. So these are the cases which are more likely to go for ectopic, where there is hyper ovulation. Also try to find out whether it was an IVF pregnancies, how many embryos were transferred, what day the embryo was transferred, what was the indication for IVF, is she a previous case of ectopic, has she had any previous tubal surgery, is she a known case of tuberculosis, if there were embryo transfer, how many embryos were transferred, and what was the endometrial thickness, because when there is a thinner embryo, there are studies to thinner endometrium, there are higher chance of ectopic pregnancies. And when they come for an early pregnancy and still you are not able to able to see the sac, go back, ask them how long were their cycles. Did they have prolonged cycles or short cycles? In that case, you can expect, okay, maybe this is still an intrauterine pregnancy that I am not able to see. And also, if there is spotting or bleeding in early pregnancy, be careful, because this try to differentiate whether it was just simple spotting or there was heavy bleeding, because when there are non-tubal uterine pregnancies such as scar ectopics, cervical ectopics, these patients might initially present as spotting, but often they might present with heavy bleeding. So we are obstetricians, always dig out for the history. So what is the relevance of endometrial thickness to predict intrauterine pregnancies? As obstetricians, we will always be familiar that, okay, early pregnancy, a patient has come. We have a look at the endometrium. We are not able to find the gestational sac. We will look for the thickness of the endometrium. Intrauterine pregnancy is more likely to cause decidualized endometrium, and a nice thick endometrium is more likely to be receptive and more likely to have a intrauterine pregnancies. So there are various studies that endometrial thickness can predict previous endometrial thickness, while for spontaneous or if it is an IVF pregnancy, it can predict the likeliness of intrauterine pregnancy. Means thicker the endometrium. Specifically, they have given a cutoff in one of the studies has 8 mm. If it is less than 8 mm, you should think more towards ectopic pregnancy and closely follow up the patient. If it is more than 8, maybe you can give the benefit of doubt and you can time the follow up such that so that you might probably end up having a intrauterine pregnancy. Also, what does the endometrial pattern predict about the possibility of ectopic pregnancy? We are all familiar that in early pregnancy, early intrauterine pregnancy, more often the endometrium becomes decidualized and echogenic when it is an intrauterine pregnancy. What happens when there is an ectopic? There are various studies to have seen what is the pattern of endometrium when a person is getting an ectopic pregnancy. A trilaminar pattern of endometrium with a beta HCG positive has higher specificity and positive predictive value for having a in a ectopic pregnancy. So if there is a pregnancy of unknown location, you are not able to locate the pregnancy, but you are able to see a triple layer endometrium. Always be cautious. There is a higher risk of having a ectopic pregnancy than an intrauterine pregnancy. Also, as obstetricians, we rely a lot on what is the pattern of doubling of the beta HCG to predict whether a person is going to have ectopic. We know that when the pattern is doubling nicely, we might think, okay, it is an intrauterine pregnancy because every 24 to 48 hours, the beta HCG is doubling. What happens in an ectopic? Usually there is either no doubling or there is slow plateau, or sometimes even there is a fall in the beta HCG. But this pattern might be misleading, especially when the pregnancy is a scar ectopic or a cervical ectopic. This is because a good implantation area is secure for a cesarean scar ectopic as well as cervical ectopic, and there can be beautiful pattern of doubling of the beta HCG. Still, you are going to have a scar or cesarean ectopic. I was a part of the team which managed one such case. So, sharing a case of a cervical ectopic. Cervical ectopic is the one in which the gestational sac implants in the endocervical canal. That is, it is below the internal os. There is no intrauterine pregnancies, and the implantation is within the cervical tissue. It is extremely rare, 1 in 9,000, more common in ART pregnancies, 0.1% of all IVF pregnancies, very rare in naturally conceived pregnancies, presenting a case of 32-year-old nulliparous unexplained infertility, 2 previous frozen embryo transfer. So she has undergone her 3rd fresh embryo transfer. You can see the beta HCG doubling pattern. On day 12, it is 700 plus. Day 14, and that is after 48 hours, nicely doubled, 1,500. Day 16, again nicely doubled, 3,100, but no signs of intrauterine pregnancy. Since she had 2 embryo transfers, they thought maybe it is very early twin pregnancies, and that is the reason we are not able to see a gestational sac within the uterus. On day 19, she presented with heavy, painless vaginal bleeding, and this was the picture. You can see the first image, that is, there is an empty endometrial cavity. Almost it was a triple layer pattern. And then you can see the cervix. There is the ectopic pregnancy sitting inside the cervix with it was a monochorionic ectopic with double yolk sacs and fetal pole with cardiac activity. Here the pattern of beta HCG doubling was highly misleading. So management, all the precautions were taken, all concerns were taken for uterine artery ligation, because we expect a lot of bleeding in such cases. Intrauterine gestational sac methotrexate was given along with systemic methotrexate. And in fact, this patient required, there was a sharp fall in beta HCG. Later, there was some rise. And in fact, for the second time, the patient needed suction evacuation, after which the beta HCG came down. So cervical ectopic is a rarest form of ectopic. There can be normal doubling of the beta HCG. It might be really challenging to diagnose and manage. So these are some important clues which can be used. Another challenging scenario is heterotopic pregnancies. So this is a special case of a heterotopic pregnancy. That is, there was a scar ectopic along with the intrauterine ectopic. The unique thing even about this patient was, of course, there was an intrauterine. When there is an intrauterine pregnancy along with ectopic, beta HCG levels will be highly misleading, and beta HCG was doubling. And this such patients, we can't use it as a guide for diagnosis of ectopics. So you can see a scar niche here. This is an ectopic pregnancy sitting at the previous cesarean scar, and there was an intrauterine pregnancy as well. Since it was the patient's second pregnancy, she wanted, there was an option for selective termination of the cesarean scar ectopic. Patient wanted both systemic therapy along with intralesional therapy for cesarean scar ectopic. So according to the latest guidelines, they suggest that systemic therapy alone should not be used for either scar ectopic or cesarean either scar ectopic or cervical ectopic. It is better to use both cesarean and a local form of treatment. Cesarean scar ectopic, the diagnosis is again very crucial. We have to see an empty uterine cavity. We can see the gestational sac embedded in the previous scar niche. If we draw a line from the uterine cavity along the endocervix, usually we will see that this implantation, more than 50% of the pregnancy will be above this line drawn from the uterine fundus to the endocervical canal. Sometimes lower uterine implantation, which is not a scar ectopic, can also be a differential diagnosis. Such cases we might have to give it some time, wait and watch, or we can even use color Doppler to see the vascularity, whether it is trying to grow towards the bladder, and it might, again, the diagnosis can be slightly tricky. So for cervical ectopic, scar ectopics, usually these present with vaginal bleeding, and the differential diagnosis will be an inevitable abortion. That is a pregnancy which is about to get aborted. The things that can help us to differentiate is the amount of bleeding. When there is in early pregnancy, which is in the process of abortion, you don't expect such amount of fresh bleeding. Both cervical and scar ectopic present with lot of painless bleeding, severe amount of painless hemorrhage. The location, follow-up, beta HCG patterns might all help us to differentiate between the three. Last topic, that is retained products of conception. How thick and how much is clinically relevant. So according to recent studies, a thickened endometrial complex of more than 15 mm, which lasts for more than 2 weeks of termination, is what is significant when it is just an echogenic endometrium. Otherwise, if you are finding a proper intrauterine mass, or if you are able to see the products on the gestational sac or the fetal pole, then definitely it is a retained products of conception. So there is also a classification. You can see that whenever you receive a report, your radiologist or a fetal medicine specialist would have mentioned the vascularity. What is the relevance of such a vascularity? There is a Glutenberg classification which classifies retained products of conception according to the amount of vascularity. 0 when it is avascular, 1 when there is minimal to no vascularity, 2 when there is moderate, and 3 when it is hypervascularized. So this vascularity guides us whether this products will need conservative management, or it might get it might need some intervention like curettage or maybe hysteroscopic evacuation. So this is the 4 types of retained products of conception. Mainly based on color Doppler. You can see sometimes when you are following up your patients, such hypervascular images you might get. And what is usually when we see such lesions, one scare that we get is this AV malformations, because AV malformation is an extremely rare condition, and we are scared that such a thing might cause some, even if we are trying to decide upon an intervention, it might result in lot of undue hemorrhage. It causes a lot of panic both for the gynecologist and for the patient. So is there a way we can differentiate it? Of course, along with color Doppler, we can take a spectral Doppler to see what is the resistance to flow, what is the velocity of flow, which will guide us whether it is AV malformation or it is just enhanced myometrial vascularity secondary to retained products of conception. We have to remember that in an AV malformation, usually there is a history of some surgery, some intervention. Maybe it is post curettage, maybe it is post manual removal of placenta. Usually they are nicely confined into the myometrium, and there is usually it is persistent. And the treatment is, of course, AVM are likely to bleed heavily. They are extremely rare, but usually it is safer to deal with them after a selective embolization of such an AV malformation. Enhanced myometrial vascularity, it is at the junction of the RPOC and the myometrium. It is not really in the myometrium by itself. Usually you can see a large retained products of conception, and they are more likely to undergo spontaneous regression. They can be taken for expectant or surgical management. Whenever there is such hypervascularity, especially when associated with molar pregnancy or cesarean scar pregnancy, the likeliness of AV malformation is higher, and we have to watch out for them. So to conclude, of course, color Doppler has led to overdiagnosis of AV malformation, but we can use certain clinical history and symptoms to rule out such an AV malformation. We can continue to monitor and decide whether really any intervention is required. Just noting the high peak systolic velocity might not be always indicative of AV malformation. So the the gold standard for diagnosis of AV malformation will be angiography. So post confirmation with MRI angiography, we can go ahead with some interventional radiology procedure so that we can minimize bleeding. And also, if it is otherwise not indicative of AV malformation, just hysteroscopic or simple evacuation might help. So to conclude, I will say that we are really blessed to have such knowledgeable webinars, and we have generous people like the stalwarts here today to help juniors like me to gain knowledge. We are empowered with so many tools. Ultrasound is like an extended hand for an obstetrician. So we are gaining a lot of information. We are trying to analyze better, but we should always remember that with such great power comes greater responsibilities. I'm so grateful for this opportunity, and I'll hand over it to Milan Shah sir to put some concluding remarks.
Yeah. Thank you very much, Dr. Navya. It was really a very mesmerizing and wonderful, quite elaborate talk, because I understand in given 20 minutes to cover this first trimester challenge was really, really admirable what you had done, because all those points which we were keeping in our mind whenever we do actually the first trimester scan, you have covered it very well, and I'm very sure all those delegates will be very, very happy to clear their doubts about this particular problem in the first trimester scan. Especially your emphasis on the heterotopic pregnancy, which is, previously we always used to say that it's a rare entity, but it's no more a rare entity now, as we can find a lot of patients now come with heterotopic pregnancy because of treatment of infertility. With this, let us start with another talk, which is again a very important talk about the genetic sonogram, because so many soft markers we nowadays actually find, and then patients, they always get worried that when they find certain things in the choroid plexus, whenever there is slight collection in the renal pelvis, and then they come to us, doctor, please tell us what needs to be done. But good that we have a good armamentum of good investigations which we can do now. And here we have Dr. Chitra Ganesh, who is a very senior fetal medicine consultant from Bengaluru, Ma Kaveri Hospital. Can I have her CV, please? Yes. She got her training under Dr. Suresh and Dr. Indrani Suresh, a very close couple friend of mine, and always been, training so many of my students as well under their Mediscan. But I'm also happy to see that Dr. Chitra also has trained more than 800 students across the nation for ultrasound in the obstetrics. And that's really wonderful of you. She's a consultant and director at Karthik Hospital, Karthik Scan Center. She's the secretary of Medical Ultrasound Society of Karnataka. She's the vice president of Society of Fetal Medicine of Karnataka chapter. Nowadays, all these state chapters also doing a lot of work to create awareness, and I'm very sure that under your leadership that must be happening in the Karnataka as well. She's also a president of the ISOCS Karnataka chapter. And with this, Dr. Chitra, my stage is yours to explain us about genetic sonogram and how we can utilize that for our practice. Dr. Chitra, please.
Yes, sir. Thank you, Dr. Millen, for that excellent introduction. First of all, I should, in fact, thank and appreciate the effort taken by the genetics and the fetal medicine committee of Kasoga. In fact, this is one of the best initiatives to have a series of webinar, especially on a focused topic like fetal medicine, which is again split into multiple stages. So it would have been excellent if we were there personally to see you all, but then probably sometime later we will make it up. And with this, we start our presentation. In fact, Navya had started the whole session with an excellent talk. It was excellent, Navya. Now, can I share my screen?
Yes, ma'am.
Yes.
You can share.
I think you're able to see that. Are you able to see the screen?
No, ma'am.
No.
I'm sorry, we did it once. I have to share my screen.
Yeah. Meanwhile, I'm happy to inform that we have more than 100 logins, and people from the adjacent states are also able to be part of this wonderful webinar, which is the beauty of having a Zoom webinar in the comfort of your homes and the comfort of your time. I would also like to mention that maybe we can have a question and answer session after the two speakers are done with their talks.
Yeah.
Over to you.
Yes.
Yes,
With your reports, Dr. Rajasri, that you had put in, so many people have logged in. Yeah, Dr. Chitra, please.
Yeah. Yes. Now let us start with the definition of what is a genetic sonogram. This is an ultrasound examination which is done in the second trimester of the fetus, which is between about 18 to 22 weeks of gestation, where we look into two things. One is the structural malformations as well as the sonographic markers of the Down syndrome. When we say markers, these are just findings in ultrasound. They are per se by themselves not an abnormality. You do get some interesting feature in an ultrasound which is different from other fetuses. And these are the variants which are more frequently seen in Down's babies as against euploid fetus. Some of the euploid fetuses also have, but the incidence is little more in Down's fetus. So we give importance to these markers. So what is the goal of our genetic sonogram? It is basically to improve our detection rate of this aneuploidy, that is trisomy 21, and also to reduce the intervention, that is amniocentesis rate, thereby reducing the fetal loss. So when you come to the second trimester soft markers, these markers have undergone tremendous changes over years. Some of them which were thought to be very important, like a widened sandal gap, widened pelvic angle earlier, has now disappeared from the scene because they are no longer very sensitive or specific for trisomy. Some newer markers are added on, especially the absent or an hypoplastic nasal bone, ARSA, which is the aberrant right subclavian artery, ventriculomegaly. These are added on as markers because their incidence in Down syndromes are found to be more. And there are certain markers which were earlier considered as an aneuploid during the process of aneuploidy screening, like your choroid plexus cyst, single umbilical artery. Of course, they are markers for aneuploidy, but they are not very specific for Down syndrome. So when we talk about the second trimester soft markers for Down syndrome, when a patient has a marker which is related to Down syndrome, along with that, if she has any choroid plexus cyst or a single umbilical artery, that does not add on her risk for Down syndrome because these are not specific for trisomy 21. Coming to the other important chromosomes, that is 13 and 18, We all know that these two aneuploidies are incompatible with life and they exhibit multiple structural abnormalities which can be detected in ultrasound. In fact, ultrasound is about 99 to 100% specific when it comes to picking up these aneuploidies. So there is no role of soft markers in increasing or reducing the risk when there is a concern about T13 or T18. So focus of this talk will be mainly on the clinical value of the soft markers as a screening tool for Down syndrome. Overall incidence of Down syndrome is about 1 in 800 live births, and the incidence increases with the maternal age. The cutoff, most of the screening test used is 35 years. This is an arbitrary number because above 35 years, the incidents are found to be doubled, but that need not be specific. These can be managed as per your institutional follows. 70% of the Downs, as we all know, will be born to women less than 35 years. So that when we address a screening protocol, it is important that all women, irrespective of the age group, undergo the screening process. And this forms a rationale for a universal screening. So coming to the ultrasound soft markers, when you see a Down's baby right in front of us in a clinical setup, we see a thick nuchal pad of fat, a downward slant of, upward slant of eyes, some palmar crease, and these are all the phenotypic features which can be identified in a Down syndrome fetus, babies. Is there a possibility of identifying these phenotype features earlier by ultrasound? That is what is the attempt made when the before the soft markers came into vogue. All these markers need not be seen in all cases. Many a times, markers may not be present in the Down's babies also. Each marker, when they are present, they also have a different sensitivity. So the importance or the key points when we are screening for soft markers is the person who screens understands the technique. That means, how do you get the marker, whether whatever you have done by ultrasound, whether the technique used to identify them is done properly. Once you get a marker in ultrasound, how do you interpret? And the importance of auditing your own images in your own setup, how much is the incidence of the soft markers association with Down syndromes. So effectively, these screening processes are a filtration in the screening protocol itself, of which, as Doctor had already told, there are armamentarium of investigations which is available to us now in the first trimester. And once these, if the patient does not had any of these things earlier, or if they already have a previous screening process, the importance of the genetic sonogram is to add on to the filtering process so that the incidence of Down syndrome becomes much more specific. So what are the tools we use for screening? In the first trimester, we resort to ultrasound markers like nuchal translucency, nasal bone, ductus venosus, and tricuspid regurgitation. In the second trimester, yes, markers which include the nasal bone, which may be unossified or hypoplastic, increased nuchal fold thickness, and other soft markers. Biochemistry, in the first trimester, we include free beta HCG and PAPE, and in the second trimester, quadruple screening. All of these tests which are used in different trimesters have varying efficacy. Earlier in the second trimester, we were dependent on the Benacerraf scoring set system, which included all the major anomalies, a score of 2, and the minor markers were given a varying scores. And the most important soft marker which Benacerraf had included is only nuchal fold thickness, which was given a score of 2. And anybody who had a score of 2 or above were considered for the intervention or amniocentesis or a confirmation test. That is how it started earlier. Now we know that is not possible, and that's the sensitivity of such a type of screening is not high. And therefore, we now all of us follow this Agathocleus and Nicolaides group meta-analysis, which was done in 2009 to 13. They have identified 9 soft markers in the second trimester. And each of these markers are given a value as a likelihood ratios, or which is maybe positive likelihood or a negative likelihood or an isolated likelihood ratio. So what is this likelihood ratio? It is a number which is given to each marker which tells the probability or the chance of the woman having a Down syndrome because she has tested positive for this marker. For example, if the LR or the likelihood ratio of a marker X is taken as 5, the woman who has tested positive, that means who has a marker identified in ultrasound, has a 5 times higher chance of having a Down's babies, that is 5 times above her background risk or an adjusted risk or an a priori risk, which means if she has done her first trimester screening, the FTS risk is taken as an a priori risk. If she has not done her 11 to 14 week scan or a first trimester screening, her maternal age related risk is taken as an a priori risk, and that risk increases 5 times because she has this marker. So likelihood ratio is nothing but the efficacy of a marker. How is it calculated? It is calculated as a ratio of the incidence of the marker in Down's fetuses by the incidence of marker in the normal fetus. So it can be a positive LR, negative LR, or an isolated LR. What do you mean by positive LR? Positive LR means it tells the chance of a woman having a Down syndrome because she has tested positive for a marker. This woman has one of the markers, say absent nasal bone or an increased nuchal fold thickness, which means she has a 3.1, or depending upon the LR given for that marker, that probability increases because she is positive, she's got that marker. A negative LR, it tells the chance of a woman having a Down's baby because she has tested negative for that marker. She does not have the marker which is sensitive for Down syndrome. Therefore, her chance reduces. That means negative LRs are always less than 1. It is given in decimal. So, final risk is then calculated as a priori risk, which is a pre-existing risk, maybe a maternal age-related risk or an FTS biochemistry risk, multiplied by the positive LR and the negative LR. What is isolated LR? Isolated LR means positive LR of the marker present, of the single marker which is present, multiplied by the negative LR of all the other markers which are not present. So you don't have to do the calculation for each of these. Isolated LR itself is given in this tabulation. So if you have this table in your consulting room, it is very easy to calculate and tell the patient whether her pre-existing risk is increasing or decreasing based on the single marker. So interpretation of the LR, identification of a marker itself has no meaning. So just putting in the report that bilateral pelvic tesis or a mild ventriculomegaly or an increased nuchal fold per se does not give us any idea of what is being changed in this woman. The final report has to be a number and it is simply not a finding. And this number has to indicate how much the woman's risk for Down syndrome has increased or decreased based on the presence or absence of the marker. So when you come to the steps of screening, you have the maternal age or the baseline risk or a priori risk. Then you get a likelihood ratio of the marker which is present, modify the baseline risk to a new predicted risk, and then finally decide on the diagnostic test based on the cutoffs which you get after the calculation. So going to the markers, first is increased nuchal fold. Any nuchal fold thickness or the thickness behind the neck of the baby, which is got in your transverse or an axial section in the transcerebellar plane between 18 to 24 weeks should be less than 6 millimeter. If it is equal to or more than 6 millimeter, it is called as increased nuchal fold, occurs in 5% of fetuses. Apart from aneuploidy, fetuses exhibiting this increased thickness are also at risk for evolving hydrops, perinatal deaths, and various other genetic syndromes. And even in euploid fetuses, there is a chance of small amount on incidence of neurodevelopmental delay in fetuses who have increased nuchal fold thickness. So the positive LR of this marker is about 23.3, whereas when it is present as an isolated marker, the risk of this patient increases by about 3.79. So how do you manage when you see an increased nuchal fold in your genetic sonogram or the second trimester scan? Check whether you have taken the measurement properly, which means many a times when patients are referred for second opinion for increased nuchal fold, when you see it fits within the 6 millimeter measurement, that is because the angle is very, very important. You need to see both the outer skin as well as the occipital bone external surface, and then put your caliper in such a way it is measured from outer to outer. And then once you know that the measurement is taken in a proper plane, use the LR and calculate the risk. And if it is more than 1 in 250, which is taken as a screening cutoff, offer counseling and amniocentesis as a confirmatory test. And of course, in all these patients, even if it is karyotype is normal, it is important that you follow them up to rule out any evolving eye drops. Then echogenic intracardiac foci, yes, a small white dot in the heart is enough to cause anxiety both to the obstetrician as well as the patient. Occurs in 4% of fetuses. This incidence is much more in our Asian community. In fact, every OPD, we have at least 2 to 3 patients having this ECF. It is important that first you rule out any cardiac defects in these babies. And if you know that it is an isolated marker and no other marker is seen, do not alarm the patient. Go back and check on her previous, what is her FTS risk or an a priori risk. And if that risk is low, don't even mention talking about aneuploidy to this fetus. But since it is important that all of us who are practicing imaging, that whatever we see, we need to report it. And therefore, report it in the body when you are explaining the anatomy of the fetus. Thus, echogenic foci seen in the left ventricle, no other markers. Do not put it in the impression and alarm the patient. That is very important because as you see here, if it is an isolated marker, the LR is just about 0.95, which is less than 1. That means her a priori risk is not going to get changed. In fact, it may slightly reduce compared to her previous existing risk. Coming to mild hydronephrosis, now all this urinary tract dilatation are termed as UTDs or urinary tract dilatation. Whenever the AP diameter, which is measured in the transverse plane, is more than 4 millimeter during your mid-trimester scan, that is when you do your genetic sonogram, it is called as hydronephrosis. Whether it can be unilateral or bilateral, it is still a soft marker for aneuploidy, can occur in about 1 to 2% of fetus. If the measurement is more than 10 millimeter or it is associated with calyceal dilatation, it implies obstruction and it is not a soft marker. You have a 5 millimeter pelvic ectasis associated with calyceal dilatation, then don't call it as a soft marker. It is more in favor of an obstructive pathology. Again, as an isolated marker, the LR is just about 1. So this isolated pelvic ectasis again is not going to change your a priori risk. But what you should do is, it is important that it can be a marker for an evolving obstruction which can be picked up later in gestation. So serial scans are mandatory. It is not needed to scan the patient frequently to see how fast this is progressing or regressing. As you go on to your growth scan in the next sitting, it is enough that you check the pelvis at that time. And if it is an isolated marker, again, as like ECF, there is no role for talking about aneuploidy to this patient. Now comes the echogenic bowel. Yes, this is another of one of the marker which is overcalled with all our high equipments, high resolution equipments. In fact, most of our Oluzon equipments or the GE equipments, which has high degree of contrast, much more, this is for false positivity is becoming much more with this marker. It occurs in 0.2 to 1.8% of fetuses. The common causes of this is an intraamniotic bleed. Patient would have had an earlier bleed during an earlier trimester. The baby would have swallowed the blood, which can present as an echogenic bowel. It can also be a marker for infection. And of course, it is a marker for Down syndrome. It can also represent placental ischemia, that is placental insufficiency, IUGR, and therefore has to be followed up. And rarely when there is a history of consanguinity or when the patient comes from a belt where cystic fibrosis is high, it is important that we discuss cystic fibrosis also with these patients. And it is a highly subjective phenomenon. So we have to be very careful before calling. It is important that we reduce the gain of the machine and then make everything dark in the fetal abdomen and slowly increase the gain. And when the bowel is visible, and the visibility and the echogenicity of the bowel is as much as the bone which is nearby, that is either the hip or the femur bone, then you call it as an hyperechoic bowel. As an isolated marker, the LR is about 1.65. So whenever there is an echogenic bowel identified during your genetic sonogram, ask for history of bleeding, do maternal torch IgG, IgM to rule out infection, fetal infection as a cause. And if there is nothing, calculate her new risk, and depending based on the risk, you offer her the procedure. And of course, since it is a marker for placental insufficiency, it is important that all these patients undergo interval growth scans. Coming to short, long bones, short femur and humerus, we call them the limbs as short when their length is less than the 5th centile for the period of gestation. When all other parameters are normal, and if it is an isolated finding, when we say all other parameters are normal, it is important that you are ruling out any skeletal causes for this shortening of the bone. That means you look into the length of the bone. First is measure the bone, see how much is the echogenicity, whether it is bright, throwing shadows, mineralization is good, whether the shape is correct, whether there is no bowing or fracturing of the bone. Then look for other markers of skeletal abnormalities like the thoracic circumference and certain ratios like femur-foot ratio, etc. And then decide that this is not a part of a skeletal anomaly, but it is only a simple shortening of the bones, especially femur and humerus. And as a marker, humerus, short humerus has a little more likelihood of having an association with Down syndrome. So it is important that we consider skeletal dysplasia, check for fetal growth, because even during placental insufficiency, when there is an IUGR, the first bone, the first redistribution occurring is shortening of this femur, because the baby starts supplying less to this skeletal system, and therefore short femur itself may be an indication of a placental insufficiency, and it is important that we do serial scans to monitor growth in these patients. Mild ventriculomegaly, this is again a new marker which has been added. The width, whenever the width of the lateral ventricle is more than 10 millimeter, we call it as ventriculomegaly. And when it is between 10 and 12 millimeter, we call it as mild ventriculomegaly. When it is more than 15 millimeter, it is generally associated with an obstructive pathology like an aqueductal stenosis, etc. When it is a mild ventriculomegaly, it can be a marker for Down syndrome. It occurs in about 0.3 to 0.8% per 1,000 live births. It is important that once it is identified, we modify the risk status because it has an LR. As an isolated marker, it has an LR of about 3.81. So far, you had seen markers where the LRs are just ranging between 1 and 1.6 to 1.8. Now we have a marker which is 3+. So it is important that we also do an infection screening because ventriculomegaly is also a part of manifestation of fetal infection. Ventriculomegaly associated with fetal infection are distinct by the presence of calcifications along the walls of the ventricle, and they can also have other features of infections like growth restrictions, calcifications in the liver, calcifications in the abdomen, etc. Follow-up scans are essential, and fetal MRI is one of the other mode which we normally resort to after 26 to 28 weeks of gestation to rule out evolving brain parenchymal pathology. If it is an isolated finding, that is mild ventriculomegaly, where the dilatation is less than 13 millimeter, it has a good short-term neurodevelopmental outcome. So a couple can be told about this and can be reassured. The next is ARSA. This is again a new marker which has come into vogue. It is technically difficult to get this because it is only by color Doppler we can pick out this aberrant right subclavian artery going behind the trachea. Because color Doppler is the way of identification, it is important that it is angle dependent. So it is technical, a person has to be trained to identify ARSA itself. And it is a much better marker than ECF and hydronephrosis. So since it is a difficult marker to get and time consuming, depends on the fetal position a lot, Are we going to get ARSA, look out for ARSA for all the time? It is an policy which an institution has to take. When you are a fetal medicine unit or when you are training to become a fetal medicine person, it is important that you start getting trained or getting equipped yourself in identifying all these markers. Put in that extra effort to identify. There may be a learning curve, but once you identify it and incorporate it, it is very important because as an isolated marker, ARSA carries an LR of about 3.9 to 4. That is, it is now becoming better than ventriculomegaly. So it is important that ARSA has to be included once you become technically equipped with that. And now we have the final marker, which is the unossified or the hypoplastic nasal bone, which is seen in 1 to 2% of normal fetuses, but 62% of trisomy 21. Because the incidence is much higher with Down syndrome, it is one of the most sensitive marker with an isolated LR of about 6.58. So this again is a technically challenging imaging thing to find out or to diagnose or to put in report that yes, this nasal bone is absent, present, or it is small, whether it is a single nasal bone, right or left, whatever it is. If the measurement of the nasal bone is less than 2.5th percentile for that period of gestation, we call it as an hypoplastic or a nasal bone. Or if it is unossified, we don't see the nasal bone at all, then you confirm it in different sections. And once you're sure that it is unossified and it is just not a false positive diagnosis, you need to offer counseling to the patient, address to her on the aspects of its association with Down syndrome and its being one of the strongest marker in the second trimester, and then offer amniocentesis. So knowing these markers now, how do we apply it in our practice? Coming to isolated marker. So this was a case of a young primee who did not have a 11 to 14 week scan, came directly for genetic sonogram at about 16, 17 weeks. So she was offered only quadruple screening before that. So quadruple screening report for risk for trisomy 21 was 1 in 175. When she came for genetic sonogram with this report of the mid-trimester, second trimester biochemical risk, a detailed examination of the fetus was done. There was no gross structural abnormalities. The only marker which was present was hyperechoic bowel. So this was a 16 to 17 week fetus with only hyperechoic bowel, no other markers. Now, how do we proceed? We know her pre-existing risk is 1.7, 1 in 175. Go back to the table, find out what is the LR of this isolated marker echogenic bowel. LR is 1.65. So her risk is now going to increase 1.65. So take 175, divide by 1.65, it becomes 106. So her modified risk now is 1 in 106, which becomes quite high. Now you can discuss with her about what is the next option she would like to take and the importance of doing a definitive testing now to confirm or the normalcy of the fetus. What will happen when you have multiple markers? How do we proceed? For example, here is a patient whose first trimester risk, that is a combined first trimester screening, both NT and double marker was done. Her risk was 1 in 500. Her genetic sonogram showed echogenic intracardiac foci with mild pelviectasis or hydronephrosis. Now she has 2 positive markers. So echogenic foci, which has a positive LR of 5.83, and mild hydronephrosis, which also has a positive LR of 7.63. But this lady does not have the other markers. She has 2 positive markers, but there are other 7 markers which are all negative. So when you are calculating a final risk, that is the final LR, you need to multiply the positive LRs with all the negative LRs which she does not have. And so her final LR now becomes 5.82. Now modify a risk of 1 in 500 by 5.82. Her risk now becomes 1 in 85. We had earlier seen that ECF and mild hydronephrosis, if they are present as an isolated marker, absolutely has no value, does not increase the risk of the aneuploidy in the patient more than the a priori risk. But when they are present together in the same fetus, the risk becomes considerably high. So this is how you calculate it. What happens if my genetic sonogram, which is done in the mid-trimester, is totally normal? That means I do not have any of those markers. The risk reduces by about 7.7 times from your a priori risk when you use all the 9 markers, including the recent ones, ventriculomegaly, ARSA, nasal bone, etc. That means a risk of 1 in 500 becomes 1 in 3,850, which is quite reassuring. If in a couple who does not want to do any intervention or scared to do any intervention. Suppose if you do not use these markers, specialized markers like ventriculomegaly, nasal bone, or ARSA, because they are technically difficult and you do not know to do it perfectly, still when you do the other 4 markers, without these also, the risk with the other markers being done, the risk reduces by about 3 times. So that is how interpretation based on the markers occurs. When it comes to the efficacy of the screening test, we have the genetic sonogram, which is done in second trimester, which includes structural anomalies and soft markers together. The detection rate is 70% for a false positivity of 10%. Whereas your first trimester, that is NT plus double marker, has a detection rate of about 90 for a false positivity of 5%. And NIPT, which is now into vogue, has since down a detection rate of about 99% for a false positive of 0.1%. So when you have an option, when the patient has not had any screening test before, or when the patient is reluctant to do any of the screening tests in the early trimester, it is not correct on our part to offer only the second trimester soft markers as a screening test. So when the patient has not had any screening test in the earlier and she directly comes to you in the second trimester and you do the genetic sonogram, you identify 2 markers, it is important that you offer NIPT as a choice at that point instead of only modifying our maternal age risk based on this thing. Because the sensitivity or the efficacy of the screening program becomes much lower if you use only genetic sonogram as a screening test for trisomy 21. So what is the role of genetic sonogram in this era where first trimester screening and non-invasive prenatal testing, that is NIPT, is being used in many patients and in almost most of the patients nowadays? As compared to your first trimester screening test, the only thing the genetic sonogram does is it does not increase the detection rate, but only reduces the false positivity. Suppose if you use it on a patient who has already had a first trimester, it reduces the false positivity. And it also helps in assisting and decision making in women who have a risk cutoff which is very close to the, say, suppose if the patients, you take the screening test result as cutoff as 1 in 250, the patient has a risk of about 1 in 300 or 1 in 400. Which are the intermediary risk, because we know only low risk and high risk. Now we have an intermediary risk group. So what are the things you need and offer to them if the patient is reluctant to do the intervention? Then genetic sonogram is one of the things you can offer. But when NIPT is being done in the first trimester, patient has had an NIPT at 10 weeks, 12 weeks, whatever it is, or based on her FTS risk, he has already had an NIPT which shows negative. That means her NIPT shows she has got low risk for Down syndrome. Then there is no further genetic screening to be offered, which means genetic sonogram itself has no relevance when the patient has a negative NIPT with her. However, you still have to do a mid-trimester scan. And when you are doing a mid-trimester scan, apart from anomalies, structural anomalies, you need to look into these markers basically because some of these markers are an indication for evolving problems like echogenic bowel, short long bones, pelvic tasis, etc. And hence in these patients, you need to, even if you identify the marker, it is basically for a further follow-up and postnatal management rather than altering a risk for aneuploidy. So if an NIPT is done, genetic sonogram has no value as a screening for Down syndrome. So this is one of the flowchart in one of the studies they have done. So in a patient with a normal first trimester scan, in the mid trimester, they do the soft marker. And if a soft marker is present, isolated soft marker, which has no significance, not to worry. If they have multiple soft markers in the mid trimester, then NIPT is offered. And if NIPT is normal, then they just follow up the markers for the evolving problems. Suppose if cell-free DNA testing was abnormal or no call. No call means sometimes NIPT report comes inconclusive and they will ask you either to repeat the NIPT again or to go in for intervention. It is always worthwhile to go for intervention directly and then decide on normalcy and abnormalcy. So whatever is the protocol of screening, you need to decide among the availability among your group of patients, how do you want to proceed it? And once you proceed and have your screening protocol in place, then all the patients who come forth from the first trimester needs to be going through a pre-test as well as a post-test counseling, addressing to them all the issues of what will happen after this each test. How will your result be and what will be your next step and how do you proceed? This is very important. So to conclude, your first trimester combined screening for Down syndrome is more sensitive with lower false positivity. Effective FTS and rapid implementation of NIPT in screen positive can significantly reduce the incidence of Down syndrome. That is what we are all targeting at. Our main concept is Down syndrome incidence should come down. What are methods you use and how many screening tests you use will all depend on the reducing the incidence. So the combination of FTS and NIPT still has a higher value. Although soft markers are of little value in normal women, generating a new composite risk for patients who have 2 or more markers may improve the detection rate in structurally normal fetus, which means if a patient has not done anything before, and she comes to you in the mid trimester and she has 2 soft markers. The first option, of course, you give NIPT, but it is worthwhile to do intervention on those patients to rule out Down syndrome if the baby is otherwise structurally normal, only with the 2 important markers. NIPT is a feasible option in such cases, thereby reducing the invasive testing. So in patients, whenever we talk to the patient following or a screening test, our first choice is always intervention because that is a definitive testing. We go through the process of amniocentesis, we tell them what is the pros and cons of each of them, and then give them all the screening tests based on the efficacy. Although the presence of specific soft markers may require pregnancy follow-up, parents can be reassured that in a euploid fetus, the final pregnancy outcome is going to be favorable in majority of the patients who do exhibit markers during the anomaly scan or the genetic sonogram scan. That means patient who has had small pelvic cases, small echogenic bowel or an intracardiac echogenic foci, if they are euploid, if the patient does not have any incidence of an aneuploidy in them and structurally normal, majority of these cases will have favorable outcome. Thank you so much for your patient hearing. Now let us have the discussions and what are all the queries we will have.
Yeah. Thank you very much, Dr. Chitra Ganesh. It was really a very wonderful talk and very elaborated talk on all those soft markers. Because yes, it's always again a lot of controversy, dilemma, and needs a lot of counseling as well. When your emphasis on the NIPT was really important because yes, there is a lot of change which we have seen. I remember in earlier days that DNA yield was such an issue. And sample used to go to various countries actually in the NIPT. But now with the more advances and more laboratories which have come, the NIPT has become cheaper as well, whereby we can definitely use that tool, but we'll have to be very cautious while using that particular tool. As you said very correctly, in certain actually conditions of the soft markers, we need to follow up them as well. And all these laboratories nowadays, whenever there is NIPT screen is high or positive, they offer the invasive testing free of cost as well. So suppose we counsel our patients accordingly, definitely their actually compliance to get the non-invasive test done increases, and we can definitely utilize that tool without having that minimal risk of, whatever abortions and the other problems related to the amniocentesis or the CVS. It was really a good talk and really wonderful. I think, do we have time, Dr. Rajasri, to take questions?
I think to take the answer and questions is very relevant here, sir, because the talk was meant to clarify the doubts which the practicing obstetricians have and to apply it in the clinical practice as to how we go about this interpretation. And I would like to say a big thanks to Chitra Madam for conveying such a wonderful talk and just what we had asked for, especially the NIPT that's is so very rampant nowadays that every lab are on a competitive price to offer the test. And then having offered the test, we would also like to know how to do and interpret and go about and where it is relevant, which Madam has excellently covered in so well. Thank you, ma'am. And I think we can go ahead for the question and answer sessions.
There are a few questions. For the first trimester, they have asked, what is the cutoff for tachycardia? I think I would like to answer that. So between 9 to 10 weeks, we observe that there is a physiological fetal tachycardia where the heart rate might go up to 190. So like any other parameter in fetal medicine, there is standard charts has what is the cutoff for heart rate at each gestational age. So when it is 190 and above, it is also used as one of the markers for trisomy 13. Next question is addressed to Chitra Madam. The question is, ma'am, is there a role for cystic fibrosis gene testing in echogenic bowel? If so, in what gestational age and in what set of patients?
Now, when you are counseling for echogenic bowel, it is important that we give them all the factors which are associated with echogenic bowel, and cystic fibrosis is one. Especially if there is a consanguineous marriage or from areas where the cystic fibrosis is rampant, it is important we do the testing. But because most of these patients are not evaluated earlier, we just cannot send the fetal sample to identify for cystic fibrosis gene. We need to identify the gene present in the father or mother, whether they are carriers. Unless they are carriers, fetus is not going to get affected. So the testing becomes elaborate and costly. So that is why most of the patients, even when you tell them, they do not go through, because it comes to around 25,000 for testing the parents, and then when they are carriers, which gene, and then give the sample for testing. So cystic fibrosis, generally, though it is involved in our counseling part of it, testing wise, we do not put it, we do not use it on all the patients, only for selective patients because of the cost involved. But of course, you should give them the choice. If they are willing to go through it, it is important that they go through it, because cystic fibrosis is a killer disease when it comes after the baby is born. It is quite bad.
Yeah. Thank you, ma'am. Suman Madam is asking, when there is an echogenic focus in one of her patients, the LR was taken as 0.95 for one of the cases. And next patient, when there was both echogenic focus and pelviectasia, she has noticed that the LR was taken as 3. Madam wants to know how that works.
No. As I told you, when there is a single echogenic foci, the LR is 0.95 only.
Yes.
As an isolated marker, you just go to the table, get that number and do your calculation. Same if they have two markers, whatever marker is present, there is a positive LR, which is all whole numbers. You have for ECF, there is about 20, 25, pelviectasis, there is 130 or 35, like that, each positive number, there is a high value. So those two have to be multiplied with all the negative LRs. So when you multiply everything and keep it, so normally what we do in our clinic, we have the common markers which are normally present. ECF and your pelviectasis is one of the common markers. Sometimes echogenic intracardiac foci and nasal bone is a marker. So like that, if they are present, we do the combination and keep it ready there. So 5.82 is the constant number. You don't even have to check because we have already calculated it. When ECF and pelviectasis is present, her pre-existing risk increases by 5.82. That is a final LR. So there is no change as 3, 2 and all those things. Okay.
Yes. And we have to remember, when all these minor markers get added on, the LR automatically increases.
And you don't have to wait for your radiologist or your fetal medicine person to give you the value. You can yourself do the calculation if you have the chart.
Yes, and we can, I think, even share the Excel sheet where this calculation can be easily done.
Yeah.
Okay. Next, the question is addressed to me, where they're asking, when sometimes even in a viable pregnancy, the large amniotic sac will be seen. Is it significant? See, when the amniotic sac, extends beyond the fetal pole simultaneously when the yolk sac is present, yolk sac will tend to disappear around 13 to 14 weeks. It becomes very difficult to make out the yolk sac. Only in this 7 to 8 weeks window, when the yolk sac is actually prominent, at that time when the amniotic sac becomes really prominent around the gestational sac, then it is one of the poor markers.
Okay. I think in the answers, there is another question by Dr. Shalini Padmanabh, who asked, how early and late in gestation can NIPT be done?
See, NIPT labs says we can do it from 10 weeks onwards. But the whole thing on NIPT depends upon the fetal fraction. That is the cell-free fetal DNA, which is in the circulation of the mother. So that depends upon the amount of the DNA which has been liberated by the fetus. So younger the fetus, the chances of having less fetal DNA in the blood and no call result is going to be higher. And so bypassing your double marker window, that is your 11 to 14 weeks window, and doing your NIPT first before your NT scan is not advisable. It is better to do your NT scan double marker as your first line of screening, and based on that report, you subject the patient to whether NIPT or intervention. That means the patient will have already crossed 12 weeks. So 12 to 14 weeks onwards, anytime you can do NIPT, you can do later also. But because the result takes about 12 days to 14 days to get, and then decide whether you need an intervention or not, you need a time frame. So that is why after your FTS, anytime you can do.
Yeah, this is a very wonderful explanation, Dr. Chitra, because recently in another webinar, someone was mentioning that they have stopped doing the dual marker and they go for all cases, they do the NIPT because the NIPT is very cheaper in that particular center. But we always said that no, we have a tool available. Doesn't mean that we'll have to apply to every patient. And it's a good explanation you are given to
the importance of double marker is your placenta related issues. Your PAP is going to tell you whether the patient is having a screen positive for PET, whether there's a possibility of placental related issue. So you cannot get that. And NIPT is only for trisomy 21.
Correct. Yeah.
So you cannot bypass your FTS.
Yes, very true. Yeah. That importance of trisomy 21 is very important. Yeah, correct. Good.
Another question by Chetna Arvind. If NIPT is normal, can we confidently tell not to go for invasive testing?
See, when NIPT is normal, the chance of having Down syndrome is 0.1%, which is, I won't say the patient cannot have, but the patient can have, but the chances is very, very low. So if NIPT, the patient has undergone NIPT because she didn't want to go for intervention. That is why she has taken NIPT as a choice. So if NIPT comes as low risk, now you cannot offer the patient telling her, of course, during the counseling or completion of the reporting counseling, will tell that this is only a screening test with the highest efficiency. As of now, it has a 99% detection rate, but still it is a screening test. It is not a confirmatory test. So when NIPT is negative, we generally don't offer intervention as a next choice. On the other hand, if NIPT is positive, suppose the NIPT says that the patient is high risk, the chance of having Down syndrome is not there always, though it is high. We have had patients who were NIPT positive, but Downs was negative. When we did the intervention, Downs was negative. So NIPT positive does not mean Downs. So you should not terminate the pregnancy just because she was positive in NIPT. You should always offer intervention for those patients, not the other way around.
Correct. Thank you.
There's another question, I think. Dr. Sadish wants NIPT can be done in twins, triplets, etc.
Triplets, definitely no. Any higher order pregnancies, you don't do any screening test. Screening test available is only based on the NT. You don't even do double marker for triplets. Whereas for NIPT, yes, there are certain labs who are giving us the sensitivity little better in twins, but not as efficient as singleton. But the problem here is, if NIPT becomes positive in those cases, we do not know which fetus had the fetal fraction which is abnormal. So we will again land up in doing an intervention for both the sacs. Whether it is a DCDA or an MCDA, we need to do the intervention for both fetuses. So that is why NIPT in twins is still, you need to talk to the patient. It is not that we cannot do, but these are the limitations of using NIPT as a screening for multiple pregnancies. What is our, what if our NT is more than 95th centile? Should we go for NIPT or direct invasive? So whenever NT is high, when the NT becomes high, NIPT is not the first line of choice, because NT increase may not be related only to Downs. It can be related to other chromosomal abnormalities, other genetic syndromes also. So whenever NT is more than 3.5, the first step you need to offer is only invasive testing and ask them to go for microarray, not even karyotyping, because it is associated with other conditions apart from simple aneuploidies. So you don't offer NIPT when NT is more than 3.5.
Thank you, ma'am. I think that completes the discussion quite elaboratively, and doubts cleared about the various screening tests we have for the first trimester. Thank you very much, ma'am. Thank you, sir, for being there and chairing the session and conducting the program very well. Milind sir, are you there? Shah sir? I think he's lost the connection. Thank you very much, ma'am. Can we now move on to the next session?
Yes, thank you very much, Rajastri, for this wonderful session. And it was really mesmerizing to listen to both of them, Navya as well as Chitra. And Dr. Malini, please introduce Dr. Preeti.
Yeah, good evening, everyone. Greetings from Fernandez Hospital in Hyderabad. First of all, I would like to thank Dr. Rajeshri Palladi for making me a part of this webinar. And I'm privileged to be here among the stalwarts of fetal medicine. So I would like to introduce Dr. Preeti Venkatesh, who in fact doesn't need any introduction. Okay, we have heard her talks growing up in the field of maternal and fetal medicine. So she completed her OBGYN from KMC Bangalore, and she was also a gold medalist in OBGYN from the Mysore University. She was the first person to introduce fetal medicine OBG at Manipal Hospital in Bangalore, and she has many papers, posters, and guest lectures to her credit. She has also a lot of publications. The recent one is a simple and easy technique for imaging the fetal esophagus in first, second, and third trimesters, which was published in 2018. And her special interests are fetal echo and interventional ultrasound procedures. She's also a faculty of the Gynae ultrasound training program of the fetal and gynae ultrasound programs. So Dr. Preeti Venkatesh would be talking about aneuploidy screening simplified with case scenarios. So in our OPD, more often than not, when we suggest a screening for aneuploidy for the couple, the question they first ask is, we don't have a family history of any genetic disorders. Do we still need to go ahead with this? Or there may be another case scenario where there may be a high risk for a certain aneuploidy. So what does that mean? Does it require termination? Does it require any further testing? So what tests are available? What is the turnaround time, the costs involved, and the counseling? And I invite Dr. Preeti to shed some light on this clinical case scenarios. Over to you, Dr. Preeti.
I would like to share my screen.
Yes, ma'am. Yes, ma'am.
But somebody has to stop sharing.
I have stopped sharing. Ma'am, now you can share.
Okay. Yeah. Yeah. A very good evening to everybody, and I thank the organizers for inviting Chitra and me for this talk. As Chitra has said, it is nice to have a series of webinars like this from the comfort of our home. But of course, personal interaction would have been much, much more valuable. Anyway, let's do the best with what is available. What we are going to discuss now is aneuploidy screening in the first trimester. Now, there will be some amount of overlap with Dr. Chitra's talk, but I'll try to decrease it as much as possible. As we all know, genetic problems in the fetus can be in the form of structural abnormalities, 2 to 3 per 100, chromosomal abnormalities, 1 in 700 for Downs and much lesser for other chromosomal abnormalities, and various genetic and metabolic problems, which are really very rare and cannot be part of a screening program. These two conditions occur more commonly and are amenable to screening and early diagnosis. Aneuploidies, as you all know, are numerical aberrations of chromosomes. They include chromosome 21, 18, 13, and the sex chromosomes, the commonest of which is Turner's. Triploidy and tetraploidy are rarely seen, but they also do occur. Now, these structural abnormalities and chromosomal abnormalities that we are talking about are relatively common, but they occur very randomly in the population. There is no specific risk factor that predisposes a person to a particular abnormality other than age. And age, as we all know, is not a very good screening tool. So we need to screen the entire population if we really need to pick up the high-risk population. Now, ultrasound has been very useful in identifying anatomical defects in the fetus. And so we've been quite successful in diagnosing structural abnormalities. More than 90% can be detected antenatally. And that is now taken care of almost completely. But the chromosomal abnormalities are still challenging because we cannot see them on ultrasound. We need to test these fetuses separately by karyotyping or chromosomal microarray to identify these defects. And how do we identify which fetus needs these tests? So the entire idea of doing screening for aneuploidy is to identify this high-risk group. And ultrasound is a very good technique for this screening. It helps us suspect aneuploidy when there are certain abnormalities present, or on the basis of certain markers, we identify the high-risk population. Now, as we all know, screening is something that we apply to a large susceptible population. So the entire susceptible population should be screened to find out the smaller high-risk group within that susceptible population. And that is the group that is referred to as the high-risk population or the high-risk group. This dark blue is the entire population. And when you screen, you identify a small high-risk group. And most of your true positive cases will be within this high-risk group. These true positive cases are also referred to as false positive, screen positive, or invasive test rate. You will miss out an occasional patient, and that is your false negative rate. This is a small study we did several years back, mainly for presentations like this, to emphasize the fact that the incidence of trisomies increases with maternal age. So as maternal age increases, the incidence increases. However, most of the pregnancies occur in the younger age group. That is the 21 to 34 age group are most of the pregnancies. And so by sheer volume, majority of the Downs will occur in that group. So in this population, you have 80% of the Downs. And even though the higher risk is the higher age group, the number of Downs that you actually see in them is much smaller. That is why age does not matter when you select a population to screen. It has to be done in the entire population. The various modalities are age, which we decided it's not very good. Then you have the maternal serum biochemistry markers and the ultrasound markers. It can be done in the first trimester and the second trimester. You've already heard elaborately about the second trimester screening. Now we will move on to the first trimester. Now, coming to the first trimester screening, you have age, you have NT, and you have biochemistry. Now, as long by NT, I mean not just the NT measurement, NT and other markers that we look at in the first trimester. So age and NT gives you a 75% detection rate. Age and biochemistry gives you a 65% detection rate. If you do it earlier in the 11 to 14 week period, that is closer to 11 weeks, 10 weeks, you have a 72% detection rate. Now, when you add nasal bone to that, when you combine biochemistry and NT, you get a 92% detection rate. And by adding nasal bone, you get a 97 to 98% detection rate All this for a 5% false positive rate. Now compare this to second trimester screening, that is the triple and the quadruple test. They do not compare. They are much less sensitive and the detection rate is lesser. So there is no point doing a first trimester screening completely and then offering quadruple test to a patient in the second trimester. That is not needed and it will only cause confusion. Now, this is the first trimester screening that we traditionally do, that is age, that is NT, fetal heart, PAPE, beta HCG combined, that is a combined screening test, which gives you a 90% detection rate. And against that, all the second trimester screening using biochemical markers is much lesser. So that is the reason we should not be doing that after a first trimester complete screening. Now, the mainstay of first trimester screening is the NT scan and the NT measurement, which gives you the highest detection rate. And therefore, this is a very, very important image that we should memorize and try and produce when it comes to detection of looking for risk for aneuploidy. Now, the more accurate your image, the more accurate your measurement, more accurate will be your risk calculation. So unless we follow protocols to the last T, we will not get the detection rates that are published in literature. Nuchal translucency, as we all know, is just a fluid collection behind the neck of the fetus. It has diverse etiology. It is seen in normal fetuses as well. And in normal fetuses, the normal or increased NT increases with, even when it is increased or normal, it increases with gestational age. In aneuploid fetuses, this increase with gestational age occurs only in a small percentage, about 5% of the fetuses. Most of the aneuploid fetuses will have an NT above the 95th centile, above 3.5 mm, which does not increase with gestational age. 1/3 of the fetuses with increased NT will have a chromosomal abnormality, that is Down syndrome, which we are looking for. And of those that screen positive but turn out to be normal, 4% will have other abnormalities in terms of structural abnormalities or genetic abnormalities. Now, this is the, there are certain guidelines that we need to follow to get the perfect image that we spoke about. You have to do it between CRL of 45 to 84, that is 11.5 to 13 weeks, 6 days, or actually it comes to 14 weeks, 2 days. Then you have a complete mid-sagittal section. You have to magnify the image, that is the head and the upper thorax have to occupy 3/4 of the screen. And magnification should be such that you can see the edges that you have to measure very clearly. The fetus should be in a neutral position, that is the area under the chin should be a small U and not a very wide U, which will be seen in an extended head. Once you get the measurement, you have to measure the distance between the soft tissue behind the neck to the inner margin of the skin covering it. So this is the measurement you take. It's an inner to inner measurement. So these are the landmarks that you must see. One is the tip of the nose. That is this bright dot at the tip of the nose. You should see the nasal bone, and that should make this equal to sign, the skin and the nasal bone here. This is the palate. Then you have the small U that you see under the chin. It should not be very wide. That is the diencephalon. This is the intracranial translucency. That is the NT that you want to measure. That is the skin. And this is the amniotic membrane. It is very important to identify the amniotic membrane. Otherwise, we very often can measure the distance between the amniotic membrane and the skin. Now, the zygoma, or the truly called the frontal process of the maxilla, should not be seen when you get this NT image. What do we mean by that? Now, this is the frontal process of the maxillary bone. It is not a midline structure. And so if you see that, you are not in the true midline, and therefore your measurement is likely to be inaccurate. This is the maxillary, the frontal process of the maxillary bone, and that should not be seen. That is why the space between the nasal bone and the palate should be empty. That is the reason you should follow this, look at this point, so that you know that you're in the true sagittal plane. It has already been shown in FMF literature that if you do not get a perfect mid-sagittal plane, you're going to underestimate. This is the measurement you're going to get. And so you're going to underestimate the measurement, and therefore your detection rates will not be as good as you want it to be. These are the three lines you must identify. This is the amniotic membrane, that is the skin, and that is the posterior surface of the soft tissue behind the neck. Only when you get all these three clearly, your measurement is going to be accurate. Otherwise, you could easily take this measurement and overdiagnose increased nuchal translucency. When there is a when there is a cord behind the neck, there is a possibility of the cord compressing this soft fluid collection, and therefore you take a measurement below and you take a measurement above, and you take an average of the two measurements. When you sometimes with the high resolution equipment, there are two problems we have. We usually have a very thick nuchal fold, and sometimes you see this fuzzy area. If you see this fuzzy area, you must include that in your measurement, because this is the sharp line of the skin that you should use to measure. So inner surface, posterior surface of the soft tissue to the sharp line that you see, the fuzzy edge should be included in the measurement. If the nuchal fold, if the skin fold is very thick, then you should take a measurement a little inside, that is in the middle of this thick fold, so that you get an accurate measurement. This is because of SRI, or you remove the SRI or harmonics and take the measurement. These are some examples of increased NT. This is a grossly increased NT, and this is a moderately increased NT that you can see. Now, the outcome in a case of increased NT depends upon the NT thickness. Higher the thickness, greater the risk of aneuploidy, structural abnormalities, genetic syndromes, and bad obstetric outcome. Even after ruling out aneuploidy, the risk for structural abnormalities, genetic syndrome, and bad obstetric outcome depends upon the degree of nuchal thickness. Spontaneous resolution does occur, even in an affected fetus sometimes, and therefore we cannot use that as an assumption that the fetus is normal. The prevalence of increased NT at 11 weeks is 70%, whereas at 20 weeks it is only 40%, and that is because some of these NTs will resolve spontaneously. Now, this is a very important chart. It shows you that what I told just now, that the outcome in NT depends upon the degree of thickness of NT. If we keep this chart with us and use this carefully, we can counsel our patients very well. This shows you that the risk of chromosomal abnormality increases as the nuchal thickness increases. Similarly, the risk of fetal death, that is after having ruled out chromosomal abnormalities in the remaining fetuses that have increased NT, the risk of fetal death is higher depending upon the NT. Greater the NT, the greater the risk. It is only 1% below 3.5, but it is 20% when it is more than 6.5. Coming to major structural abnormalities, again, higher the NT, greater the risk of structural abnormalities. And the chances of you having a healthy live-born fetus decreases as the NT thickness increases. The chances that you have a healthy fetus above 6.5 is only 15%, whereas at between less than 3.5 mm, it is 93%, and between 3.5 and 4.5 it is as high as 70%. So if we use this chart, we can counsel our patients as to what the risk is of outcome in a particular patient with increased NT. We know this. I'm going to skip this slide. There are lots of advantages of increased of the NT scan besides screening for aneuploidies and early TOP. Not only do we look at NT, we look at nasal bone, tricuspid valve flow, and ductus venosus flow. And NT also helps us in dating, in confirming fetal viability and ruling out early pregnancy complications. It is very useful in determining chorionicity in multiple gestation, the T sign of monochorionic pregnancy, and the lambda sign of dichorionic pregnancy is very clear at this stage of gestation. The NT scan is the most effective screening tool in multiple gestation. As Dr. Chitra just discussed, in triplet gestation, we cannot use biochemical screening at all. Even NIPT is of questionable use. In twins, yes, we can. But NT, with all the tests that we can do individually for both the fetuses, is the most effective screening tool for multiple gestation. 11 to 14 week scan is the best time to look for early structural anomalies, because most of these are lethal, and when detected early can help with early termination of pregnancy. It also helps detect other types of trisomies and identify a high-risk population that needs a closer assessment at mid-trimester as well. Coming to chorionicity, the first trimester, early first trimester or mid first trimester is a very good time to detect chorionicity. It's ideal, but NT scan is also equally good. These are the various structural abnormalities that we can detect during the NT scan. Many of these have association with chromosomal abnormalities, and so it adds to our aneuploidy detection. Now, as Dr. Chitra has already explained to you, once you have your measurements, you do a risk calculation. When you have an NT measurement, a translucency measurement, you combine it with CRL and maternal age, and you arrive at a risk. In second trimester, we do this manually, but in first trimester, there are many other factors like maternal age, ethnicity, and other risk factors that are taken into consideration. And therefore, you have automated computerized calculation. And this calculation requires these three measures, maternal age, CRL, and nuchal translucency. Once you feed in that, you automatically get a risk assessment. The cutoff varies depending upon what sort of screening pattern you want to use. It could be 1 in 300, 1 in 270. It could be 1 in 250, which is what we commonly use. It could be 1 in 100 or 1 in 50, which we'll come to later. Once we take a cutoff, anything higher than that is high risk. Anything lower than that is intermediate or low risk. Now, in NT, if you use a cutoff of 1 in 250 or 1 in 270, you will detect 70. NT will help you detect 75% of the Down syndrome with a 5% false positive rate. This is how you can change using this, you can change the maternal age related risk. You can either increase it or decrease it. So even a 40-year-old lady with a proper first trimester screening can have a low risk and avoid an invasive test. And in today's scenario, can make do with a NIPT instead of going for an invasive test. Now, this patient presented with, actually she had a very early scan at 10 plus weeks, which gave an NT of 6 millimeters. At 11 weeks, 4 days, the NT measurement was 7.1 mm. This was very early, so she was called again at 13 weeks to do morphologic assessment and a CVS. And at that time, the NT had reduced to 3.3 mm. Now, morphologic assessment was done. There was no other structural abnormality. Cardia looked fine, because one of the commonest structural abnormalities with increased NT is cardiac abnormality. So this was looked at carefully, and that was looking normal. And of course, this fetus had a CVS and the karyotype was normal. Now, what I want to emphasize here is every increased NT is not abnormal. There's a lot of tendency, especially among patients, once you give an NT value that is very high, they want to just terminate the pregnancy. No, you can have a normal outcome, 15% normal outcome, even at NTs of 7 and 8 mm. So you must not terminate the pregnancy without doing tests as per the protocol. Now, this patient had, the karyotype was normal, so we went ahead with early and late anomaly scan. We did a fetal echo. Everything was normal. Pregnancy continued uneventfully till term. She delivered a male baby, 3.2 kgs, and that baby is doing very well, 13 years now. So it is possible to get normal fetuses with high NT. What you need to do is follow protocols as we have them designed for us, and do as recommended, you will not miss downs, and at the same time, you will not miss those normal babies which have high NT. This patient presented with advanced maternal age, increased biochemical risk, and increased NT, and a reverse A wave in ductus venosus. 38-year-old gravida 4 with one living child, which are alive and well, presented with NT of 3 at 10 plus weeks done outside. When she came to us, the CRL was 37 mm and NT was 19, almost 1.9 mm, almost 2 mm. And of course, it was too early to do anything else. So she was called back at the standard NT time. And at that time, the NT was 2.3 and which was above the 95th centile. So the age-related risk of 1 in 110 because of her advanced maternal age was increased to 1 in 29. So the risk was high here. Now, what we did next, the biochemical screening was done. That was, MOM was, the beta HCG was high, PAPE was low. This is exactly what happens in Down syndrome. So naturally, her risk for Downs increased to 1.3 with biochemistry. And when we did a combined test, from 1 in 29, we had a risk of 1 in 6. She also had abnormal ductus venosus flow. So of course, CVS was done. And what we got was a low mosaic for trisomy 21. Now, because she was advanced maternal age, precious pregnancy, and low mosaic, and then the culture failed, we decided to wait for an early anomaly scan and do an amnio and see whether there was an aneuploidy or not, whether it was worth continuing. Unfortunately, when she came at 16 weeks, there was an IUD. You can see the gross edema that has developed. There was gross high drops, and the fetus had died at around 15 weeks of gestation. So when you have an aneuploidy, some of these fetuses will succumb. All you need to do is follow protocols and you will not make a mistake. Now, we saw 2 cases where they presented with increased NT before 11 weeks. So what is the status of this measurement? Now, increased NT before 11 weeks behaves very similar to increased NT after 11 weeks. There's a high risk of chromosomal aberrations. More than adverse outcome in this group is more than 66%, and it is as high as 85% if the NT is more than 3.5. So now here, the adverse outcome again follows the degree of NT thickening. When the NT is more than 3.5, the risk of adverse outcome is worse. The risk of chromosomal abnormality, genetic abnormality, or structural abnormality is as high as 56 to 57% and a 10% perinatal loss rate. So overall 66% adverse outcome, which increases to 85% if your NT is more than 3.5. Live birth is also possible, but that again will be is more common in the lower NT range. 2.5 to 3.5 had most of the live births. Half of them were in that group. Coming to regression of the NT that you see at 10 weeks by the standard NT time, that usually occurs if the NT is lower. If the NT regression, if the NT is higher, that is less, if the NT is lesser than 4.5, 63% cases the NT regressed. But in the higher NT group, it does not tend to regress that easily. To increase detection rate of NT scan, we combine NT with a biochemical screening test, which is called the double screening test, where you use a test called PAPA and free beta HCG. Now, NT alone gives you a 75% detection rate for a 5% false positive rate. And if you combine it with biochemistry, you can increase it to 85 to 90% with a 5% false positive rate. Now, what are beta HCG and PAPA? They are glycoproteins produced from the trophoblastic origin, both of them, and their values are abnormal in the presence of chromosomal abnormalities. They are significantly abnormal, and that is why they are used as markers. Free beta HCG is high in Downs, 2 MOM and over, and PAPE is low, 0.7 MOM in Down syndrome. So if you have a low PAPE of 0.7 to 0.5 and a high beta HCG around 2, your chances of increased risk with biochemical screening for Down syndrome will be high. Now, beta HCG, now, when we talk of MOM is a value that is, one is normal. It is the deviation from normal that you're looking at. In beta HCG, as we just discussed, is high in Down syndrome, but it remains more or less the same throughout the 11 to 14 week period. PAPE is low, and it is much lower when you are nearer 11 weeks than when you're nearer 14 weeks. By the time you come to 14 weeks, the PAPE value is very close to what you see in normal fetuses. So the sensitivity of this biochemical screening decreases towards 14 weeks and is better towards the 11 weeks. Now, both NT measurement as well as biochemical screening are much more sensitive at 11 weeks than at 13 and 14 weeks. However, in case of NT, so biochemical screening should always be done earlier, and NT, we do it later only because we want to look at nasal bone, we want to look at structural abnormalities. So as a compromise, NT scan is done at around 12 to 12 and a half weeks, whereas for structural anomaly, 12 and a half to 13 and a half weeks. But if you really want it to be more sensitive, it has to be done earlier. A combination of an early biochemical screening and a 12 weeks NT scan is ideal, but for practical purposes, at 12 and a half weeks, both can be done because the distance from mean is fairly good at that period of gestation. So this is what I was trying to tell you. At 10 weeks, you have a 72% detection rate, but at 13, the detection rate decreases to 62%. Now, this patient with advanced maternal age, 37 years, and FTBC positive because of very low PAPE. Look at the PAPE. The PAPE value was 0.1 MOM. Because the PAPE was so low, beta HCG is near normal, but PAPE was so low that all the aneuploidies, the risk for all the aneuploidies was increased significantly. Now, these are the reports she came with. Now, when we scanned her, this was the CRL, NT was 1.3, normal, ductus venosus was normal, tricuspid valve flow was normal, and the nasal bone was seen. So what happened to the risk? Age-related risk 1 in 216. Age plus NT, because of NT was so normal, it was 1 in 4,000 and odd. But the moment you added the beta, the second trimester biochemistry, it fell to 1 in 24, and even a normal NB could not bring the risk to a normal level. It remained very high. So naturally, a CVS had to be done. Fortunately, in this patient, the karyotype was normal and the outcome of the pregnancy was normal. So even when one test is grossly abnormal, you do all the other tests, combine them, and get the risk factor. And using all the combined risk will tell you whether it is high or low. You may land up with invasive testing, but your chance of missing will be low. Here, of course, FTBC was a false positive, but that is something you will have to live with because it is only 62 to 70% detection rate, and you will have a false positive sometimes. But in this patient, you see what happened. This was a 28-year-old primie. She was screened in Germany, so you'll find that the screening pattern is a little different from what we do. She had a risk of age-related risk of 1 in 797, and her age and NT risk was 1 in 3543. She underwent a biochemical screening, which gave a risk of 1 in 166. That because the PAPE again here was very low PAPE and very high beta HCG. So naturally her risk went up. And so when it was combined with NT, she fell into the intermediate range. Now, as I said, you must follow protocols. And if you have a risk that is high you do an invasive test. If you have a risk that is low, you do not do any further testing. But if you have an intermediate risk, you have to do further testing. Put that patient in either high risk or low risk, and then go ahead. So it's not advisable to reassure this patient that everything is fine. It's not fine. She's in the intermediate range. Yes, you could do an NIPT, invasive test. You could, but then your risk is not high enough, and so it's better you get her into high risk and then do it. So look for more ultrasound markers and then go ahead with whatever test that new risk tells you. Doing a QST in the second trimester, as I said, is not as good as doing all markers in the first trimester. So this is what was done. They do not do NT, DVT, NB, DVT in all patients. So they called her back and did NB, DVT, and DV showed reverse A waves. So now she went into a high risk category, 1 in 137. So once she was in a high category range, what do you do next? You either do an NIPT or a CVS. Patient opted for an NIPT because she was young. She thought her risk cannot be that high. And so she did that, but NIPT turned out to be positive. Amnio was done, and that confirmed the diagnosis of trisomy 21. So what do we learn from this? If you have an FTBC risk that is significantly high, note, even though she was in the intermediate range finally, her risk had increased significantly, okay? So you need to pay attention to intermediate risk, don't confuse it for low risk, and you should look for other markers if you're not looking. Most of us in India look at all the markers as the primary screening, but in smaller centers and busier centers, that may not be possible. So you do only NT and you use other markers when the risk becomes intermediate. If this was not looked at, then we would have missed the abnormal DV and we would have missed the diagnosis of trisomy 21 in this patient. Again, your NIPT did the right thing, gave you a positive result, and we were able to diagnose the condition. Now we look at other markers, that is nasal bone, tricuspid valve flow, and ductus venosus flow. As you all know, nasal bone is seen under the skin in the upper part of the nose. This is the nasal bone and this is the skin. So that's the nasal bone, that's the skin over it. It should be brighter than the skin over it. It gives you an equal to sign, and distal to the skin, you see the tip of the nose, which also appears quite bright at times. So this is the finding that you look at. The more perpendicular your beam is to the nasal bone, the more accurate will be your detection of nasal bone. Extended heads can often give you false positives for absent nasal bone. Now this is a case of an absent nasal bone. You do not see any nasal bone here. This is seen in 3% of normal fetuses and up to 6% of Indian fetuses. It is seen in 60% of Down's fetuses, 50% of trisomy 18, and 40% of trisomy 13 fetuses. Now here is a patient who presented with absent nasal bone. This is not the nasal bone. The entire cartilage is seen, but it is as bright as the skin. That is not the nasal bone. So she presented with absent nasal bone. NT was also a little high. So that pushed up her risk. And the because the nasal bone was absent, her age, NT, absent nasal bone risk increased to 1 in 36. This was about 1 in 500. Sorry, I forgot to write it here. It was 1 in 500 and it increased to 1 in 36. She also had a mild TR. CVS was done and it reported trisomy 21. So it confirmed the risk of, so with an isolated nasal bone, and of course there's a, okay, you can't call it isolated. There is a mild increase in NT also, and there is a TR, and you had a case of trisomy 21. Nasal bone is a very strong marker. We should remember that both NT and nasal bone are strong markers of aneuploidy in the first trimester. This is another case of hypoplastic nasal bone at 12 weeks and 1 day. This was a 31-year-old second gravida, spontaneous conception. Her NT was 1.39, and she had an absent nasal bone. The fetus had an absent nasal bone. So what we did, we calculated the risk, age NTBC risk was low. With hypoplastic nasal bone, of course, the risk came high, but what we did is we could have either done an NIPT, we could have done a CVS, or we can recheck the bone at 13 weeks. So because she was only 12 weeks one day, we called her back and looked at it, the nasal bone at 13 weeks. 13 weeks, you could see a fairly good nasal bone. And so we reassured her. We were wondering whether we should do an NIPT. It was discussed with the patient. She decided to do an NIPT, and that was low risk. And this pregnancy turned out to be a normal pregnancy for her. And we, of course, reviewed the NT again at 15 weeks, and we could see a nice nasal bone there. So you can call them back at 13 weeks. And if at 13 weeks it is equivocal, you could even wait till 16 weeks, make sure it is hypoplastic, and do an amniocentesis at that stage. This is because if you notice here, the risk of having an hypoplastic nasal bone is much higher when the fetus is smaller. Once the fetus grows, the nasal bone becomes more evident. So 13 weeks is the best time to assess the nasal bone. That is why 12.5 to 13.5 weeks scan to look at nasal bone and morphology. Now, this is another pregnancy. It's a twin gestation, 34-year-old twin IVF pregnancy. Discordant for nasal bone mineralization. Fetus B had a normal nasal bone, and fetus A had a hypoplastic nasal bone. So the logical thing would be to do an invasive test for BA at least and rule out aneuploidy. However, the mother refused invasive test for religious purposes. She did not want to do a test because she did not intend terminating the pregnancy. Please remember, if the patient wants a selective termination, we cannot wait till 16 weeks. We have to do the invasive test. We have to do the CVS now, confirm that it is normal or abnormal. And if it is abnormal, do the fetal reduction, because the best results with fetal reduction is if you do a fetal reduction before 16 weeks. Selective fetal reductions after 16 weeks have a slightly higher risk of miscarriage. So we would like to avoid that. At 16 weeks, of course, the nasal bone was still absent. Pregnancy was continued. At mid-trimester, you had completely absent nasal bone. And if you can see now, other features of Downs have come up. There is an increased preorbital thickening, prefrontal thickening, and there's absent nasal bone, a flat face. If you notice, there's some amount of macroglossia recognized as well. So features of Downs are developing. Went to term, delivered normally, and delivered, I think, with a cesarean section because it was a precious pregnancy, and Downs was confirmed in this fetus. Now, coming to tricuspid regurgitation. Tricuspid regurgitation is a fairly common finding in the first trimester, and it is not always associated with Downs. It is seen in 1% of euploid population, and 55% of the Downs, 30% of trisomy 18 and 13. Now, tricuspid regurgitation is more common if there is at 11 weeks than at 13 weeks. By 13 weeks, it sort of tends to regress, and when the nuchal translucency is high, you're more likely to get TR. Now, the chances of false negative with TR is higher. In other words, you're likely to miss a TR if you don't do it carefully. That is the tricuspid valve. Now, when you do a tricuspid valve flow, you have to interrogate it, not just in the center, but on either side as well. It has 3 valves, and the leak could be between any 2 valve leaflets. And so if you do not do at least 3 to 4 times, you do not check the flow, you may miss. So false negative rates are quite high with tricuspid regurgitation. And that is one of the reasons they say, do not do this test in all fetuses if you do not have the time to do it. Do it only when there is a high risk. Just do the NT biochemistry or NT-NB and leave tricuspid and ductus venosus flow for the high, intermediate risk population. Coming to reverse flow in the ductus venosus, this is technically difficult because fetus moves. To get this point and not get artifacts from surrounding structures can be a little difficult. So this is a normal DV. This is an abnormal DV with reverse flow in the ductus venosus. It is seen in 3% of euploid fetuses, 65% of trisomy 21, and 55% of 18 and 13 fetuses. So it's a little slightly better marker than TR. These are the false positives. See, here you can see the ductus venosus with some reverse A waves, but this is not true reverse A wave. This is some other flow from the surrounding, where usually the IVC or hepatic vessels, the flow from those veins that is overlapping and giving you a false positive impression of reverse A waves. Here, the wall filter is very high, and you feel this is the reverse A waves, but if you correct the wall filter, that is, you lower the filter, you will see that there is flow like this here, and it is probably not a true reverse flow. This is a normal flow, and that is a reverse flow. In the here you see the gain is a little more, so interpretation can be a little difficult. And here the interpretation can be made difficult by so much of flow happening on the other side of the line. So it should be a clean flow like this for you to be able to detect clearly whether this is truly a normal ductus venosus flow or not. Coming to this case, with isolated reverse flow in the ductus venosus. This was a 31-year-old primary gravida. Her age-related risk was 1 in 716. NT was normal. Nuchal translucency decreased her risk because it was normal. Nasal bone was fine. And ductus venosus reverse flow, TV tricuspid valve flow was normal. Combining all these factors, the risk was 1 in 559. That was intermediate risk. So you cannot rest here. You have to go ahead and do further testing. And of course, we will do the biochemistry. When you do the biochemistry, the PAPE is high. Low goes in favor of aneuploidy. Here it is high, and here it is low. So it is not in sync with what you see in aneuploidies. So when age antibiochemistry was combined, you got a very, very low risk of 1 in 15,000. And combining all the factors, including the ductus venosus, which is abnormal, the risk was almost 1 in 4,000. So 1 in 3,900. And risk is low, only one isolated marker. So she was reassured. At MTAS, fetal echo was done. There was no other structural abnormality. The fetus was growing very normally. And so the pregnancy was continued without any further testing. Yes, of course, she could do a NIPT if she was worried, but the patient was quite relaxed. She accepted to continue without, she was okay to continue without any invasive testing. And so we let her do so. The growth in the third trimester was fine. She delivered at 38 weeks, a healthy baby, which did very well subsequently. Coming to combined two markers, here you have absent nasal bone and reverse A wave in the ductus venosus. So naturally, even with a normal NT, your risk is going to be very high. Absent nasal bone 1 in 19. After you have a reverse flow in the ductus venosus, you have a risk as high as 1 in 4. That is the ductus venosus flow and a hypoplastic nasal bone here. So risk is high. Even with biochemistry, which was normal, the risk remained high, and a combined final risk was 1 in 12. So CVS had to be done. Karyotype was fortunately normal, and this baby also did well postnatally. Now, coming to another case of increased reversed flow in the ductus venosus with increased NT this time. This was a 28-year-old primary gravida. NT was 5 millimeters with septation. Can you see that? Quite a bit of septation is seen. This is on TVS. That's the normal nasal bone, and this is the ductus venosus, reverse A waves. So in this patient, there was the risk was of course high, and on TVS we could see a cleft lip palate. So a cleft lip palate was also seen. So a CVS was done, and it turned out to be trisomy 13. So this goes to show that trisomy 13, 18 are more likely to show you some structural abnormalities, whereas trisomy 21 may not show you anything at all. Now, this is one of our last cases, absent nasal bone with reverse flow in the ductus venosus. at a CRL of 46. That is very early we saw. There was a CRL of 46 and absent ductus venosus. Risk was 1 in 9. We called her back at the correct time, that is 12 weeks and 4 days, 59 millimeter CRL. NT was still 2. Hypoplastic nasal bone was noted. Reverse airway persisted. And her final risk with age, NT, hypoplastic nasal bone, and abnormal tricuspid valve flow was 1 in 9 for trisomy 21 and 1 in 38 for trisomy 13. If you look at the biochemical screening, it was low PAP, very low PAPA and high beta HCG. Again, this would increase the risk for aneuploidy, for Down syndrome. CVS was done. By the time the report came, we scanned her again, and at 15 weeks, you still see a equivocal hypoplastic nasal bone as echogenic as the skin, not more echogenic, and the ductus venosus flow was still abnormal. Karyotype showed a translocation type of Downs. That is, there was a 46 and 21-21 translocation. Whenever you get a translocation type of Downs, we have to do maternal and paternal karyotyping to see where this is coming from. So that was done. Pregnancy was terminated, parents were tested, but neither of them had the translocation. So this happened to be very surprisingly a de novo translocation in this fetus. And so the risk for similar problem in a subsequent pregnancy is almost nil because the parents are not carriers of that translocation. So when we talk about detection rate with various screening tests, age NT-MB and age NT biochemistry give you more or less similar detection rates, and when you combine them together, you get a detection rate of almost 97% with a 5% false positive rate. If you want to decrease, why do you want to decrease the false positive rate? The false positive rate is also the test positive rate. You want to do as little invasive testing as possible. So if you want to decrease the false positive rate, you will have to change your cutoff. And that will make your detection rate a little lesser. But you will do that much lesser invasive testing. However, we always prefer to have a detection rate near 90. And so newer studies aimed at finding out how we could increase the detection rates and at the same time lower the false positive rates as well. We have all heard of this two-stage risk-oriented screening where you can get a 90% detection for a 2 to 3% false positive rate versus a 5% false positive rate. What you do here is you bring down your detection, your high risk cutoff to 1 in 50 or 1 in 100, whatever you find comfortable. And anything higher than that gets invasive testing. Anything lower than 1 in 1,000 gets no test at all and just continue to follow up. But anything in between gets further testing, nasal bone alone or nasal bone DVTV, whatever you want to do. And you either put them into a high risk or low risk category. This will give you a 90% detection rate with a 2 to 3% false positive rate. So what you have achieved is a good detection rate with a low false, that is, you're testing lesser number of fetuses because of your low false positive rate. At the same time, you're doing the more complicated tests like DVTV nasal bone in a smaller population. That is only the intermediate group. The low risk doesn't need it. The high risk also doesn't need it because you're doing invasive tests. It's only in the intermediate range that you're doing all these extra tests. So you are decreasing the number of fetuses that have these tests and the time taken, and you, because the number is decreased, your time factor also decreases. So you're increasing efficiency and keeping the cost low at the same time getting a lower false positive rate as well. So to summarize, NT scan is an excellent test for aneuploidy screening, even now in the era of NIPT. It is particularly useful in multiple gestations. Combining it with PAPE and beta-HCG increases the detection rate, and the false positive rate can be further decreased by using a two-stage risk-oriented screening that we just spoke about. NIPT is ideal for those for those where the risk remains in the intermediate range, and instead of doing an invasive, instead of doing further testing, you could straight away ask them to do an invasive NIPT. Or if they continue to remain after that also in the intermediate range, NIPT can be done. Or if there's only a single marker and the mother is anxious, NIPT can be done as it is non-invasive. It also helps to reduce the number of invasive testing, because NIPT has a very good detection rate, and it is going to give you, it is going to miss less than 1% of the population. So the number that you're going to test is going to be very, very low if you combine NIPT with your NT screening protocol. Thank you very much for your attention. I take any questions if time permits, or it can be done later.
Thank you, Dr. Preeti, for the very extensive presentation on the first trimester screening for aneuploidies. You have brought home very important points like universal screening, importance of the NT scan, the introduction of other markers for contingent or sequential screening when the NT alone gives a high risk. And of course, you have very well stressed the fact that increased NT or an abnormal scan need not result in a termination. We need to follow our protocols, and then if the genetic test is normal, if there are no other abnormalities, we can as well follow the babies and have a good outcome. I would suggest that we take questions at the end of the webinar for the paucity of time. Thank you very much, Dr. Preeti. Can you put on the slide for the introduction of the last speaker of the day? So the last talk for this today's webinar would be on various case scenarios for the genetic tests that are available and how we use them. We have a lot of genetic tests in the armamentarium, but one glove does not fit all. So what test is advised in what particular scenario? Dr. Vinata Surabhi is going to take us through this. So Dr. Vinata, can you please put on the CV slide? Yeah. Dr. Vinata has more than 15 years of experience in the field of medical genetics, and she is currently the senior medical geneticist at Gene Tech Lab, Hyderabad. She has successfully completed medical genetics course between 2008 to 2010 under the guidance of Dr. Anuradha. She has experience in counseling more than 10,000 families and designed medical education courses for OBGYN and pediatricians at Gene Tech. She has also a lot of papers and presented at medical conferences to her credit. Over to you, Dr. Vinata.
Thank you, Dr. Malini, for introducing me. Good evening, everyone. First, I would like to thank Dr. Rajshri for letting me into this beautiful discussion and give my inputs if I can. Dr. Navya, can I share my screen?
Yes, madam. Please share, ma'am. Yes, ma'am.
One second, ma'am. There is a So today we are going to talk about the common cases that we see in the obgyn practice, where we are basically where they need a genetic counseling. The most common cases that that are encountered are recurrent pregnancy loss, there is a ultrasound defect, or if there is a history of a child with birth defects, or even if there is a child who's with autism or any kind of disability that comes under autism spectrum disorder, or a family history of genetic disorders. Of course, most common is the consanguinity. And then there is a routine perinatal aneuploidy screening, for which I don't have to talk much, because both the fetal medicine specialists have already spoken about it elaborately, but just I will touch that topic. So first thing, we all know that genes, how do we look at genes? See, these are every cell in our body contains chromosomes, and these chromosomes are containing several genes, which are nothing but 4 nucleotide proteins, A, T, G, C. Okay, and these are the ones which help us in the bodily functions. These are the ones which encode the protein, and that helps in the bodily function of the. This is about briefly about genes. Now, what are the technology which we use currently to find out about the chromosomes or the genes? The first thing is the karyotyping, where we are looking at the aneuploidy, where we are only looking at the 5 to 10 MB of structural variations and balanced translocation. Whereas in a cytomicroarray, where we are actually looking at 50 kb and more deletions or duplications, and most importantly, cannot look for balanced translocation. Even though it looks at a 50 kb and more deletions or duplications, it is not looking at balanced translocations. Then comes sequencing. Sequencing is
slideshow, please.
It is not showing, ma'am.
It's not in slideshow.
1 second.
No, that's okay.
No, this is gone completely.
No, you can remove this.
I'll just stop this.
No, you're in PDF, so you can just increase your screen.
Is it better, ma'am?
This is better. Yeah.
So the first is karyotyping, where we are looking for the aneuploidy and balanced translocations. In the cytomicroarray, we are looking at 50 kb or more deletions or duplications, and that is the copy number variations. Whereas the third one is the sequencing. In sequencing, we are either looking at a multiple gene sequencing, that is an exome sequencing, or when we're specifically looking for one particular mutation, that can be done by a PCR or a Sanger sequencing. These are basically the 3 technologies that we use when we are using a genetic testing. Of course, there are other testings like MLPA and all that. When the case comes, I will discuss about those. Now, most important is testing the fetal sample in recurrent pregnancy loss. Recurrent pregnancy loss is a common situation that we see in the OB-GYNs practice every day, especially if we are talking about the first trimester pregnancy loss. Now, the ACMG and all other guidelines say that if you are the first year test for a fetal sample testing, especially in the POC, is a cytomicroarray rather than a karyotyping. Why do we select a cytomicroarray rather than karyotyping? See, in karyotyping, there is a chance that there is a culture failure. There is about 85 to 90% of times the cells do not grow, or the culture fails. And then, of course, it is a contaminated cell. Whereas in a cytomicroarray, there is a very less chance of culture failure, because we are looking from the DNA part of it. Okay, in cytomicroarray, it gives us the same thing, like, the trisomies, the aneuploidies also can be detected along with any other deletion or duplication, the copy number variations. So, partial aneuploidy cases also, we prefer that, I mean, cytomicroarray can pick it up. Look at this case where there is a 27-year-old female with a second loss of spontaneous pregnancy loss, no family history, non-consanguinity. The POC was sent for cytomicroarray, and we found a pathogenic deletion. There were 10 OMIM genes that were deleted. Such case, when you see that there are so many genes deleted and all and the pathogenic deletion, we know that it is a sporadic and not an inherited case. A simple parental karyotyping confirms that it is not going to recur. Whereas if you see a case where there is a 14-week spontaneous abortion and you see that there is a deletion, there is a loss of 49 genes, this is a pathogenic CNV that we have noted. We know that it is 90% times of the times it is a sporadic case, but 10% of the times it could be a balanced translocation. Such cases, we advise only a parental karyotyping, not an array in the couple, because balanced translocation are picked up only in a karyotyping. So in this case, we found out the father is a carrier of a balanced translocation. Of course, all balanced translocation, there is 15% recurrence risk in every pregnancy, and there is a prenatal option that can be given for all future pregnancies. Now, in case of where there is an ultrasound findings, as we all discussed, it can be basically advised for an invasive testing where there are multiple ultrasound findings, not for a single soft marker. In such cases, in this particular case, it's 20 weeks, we have done they have terminated the pregnancy because of multiple ultrasound findings, and the POC was given for cytomicroarray, and we found a pathogenic duplication, Potocki-Lupski syndrome. This is again a dominant condition, so the recurrence risk is very low for this kind of in future pregnancies. As I mentioned, ACMG says cytomicroarray should be the first year test for any syndromic presentation for multiple fetal anomalies noted in the ultrasound, and not karyotyping. In all cases, we do not suggest a parental array. Parental array is suggested whenever in a POC sample we found that the variant that is identified is of uncertain significance. That means it is not matching with the phenotype of whatever is found in the ultrasound. In such cases, we suggest a parental array. If one of the parent also harbors the same VUS, then it is a non-pathogenic and that is not the other cause for the ultrasound findings. Then we call them, then we ask them for a further testing, which is like, exome sequencing or anything. If one of the parents harbor it, then it is called non-pathogenic. But if it is that both the parents are not having this kind of mutation or the pathogenic this thing, then we call it likely pathogenic, and we know the reason for the findings in the fetal sample. So not every case is advised for a parental array, only where it is required and we feel that it has to be tested in the parents, because whatever is identified is something that is not a sporadic event. Okay. Now, most important is, whenever there is a POC sample, we always ask patients and the practitioner to suggest for a DNA storage, because even though ACMG guideline says that the first year test is a cytomicroarray, what if the cytomicroarray result is inconclusive and we have not come to we have not found out the reason for the condition in the fetus? Then a further testing is needed. A DNA stored with the lab will help them test probably on exome sequencing or testing in the parents, and then a confirmation in the DNA sample. So for all this, we advise them that a DNA storage is also advised, even whether they go for the test ACMG guidelines or cytomicroarray first or not. When the termination is done, initially store the DNA. The test can be decided and can be done at a later point of time. That is one of the reasons why we suggested DNA storage. Now, in cases where the parental karyotyping is normal, okay, for all recurrent pregnancy losses, the first thing we all test is for a parental karyotyping. Now, what in cases where the parental karyotyping is normal and there is a recurrent pregnancy loss, or in cases of IVF, there is an implantation failure? Now, what we do for that is, there is a beautiful genomic fertility analysis that has been developed by Dr. Anuradha. This is a test that is an analysis done which looks for all the genomic variants that are responsible for the recurrent pregnancy loss, right from the thrombophilia or high oxidative stress, immunodysregulation, all these things. In this particular case, we can see we have identified 3 genotypes. These 3 genotypes mean that the calculation says that it has a 5-fold increase in RPL, and for such cases, a therapeutic and anticoagulant is necessary. An aneuploidy risk is also there for MTHFR and MTRR genotypes. In such cases, NIPT is mandatory, or if they are going for an IVF, a PGTA, that is pre-implantation genetic testing for aneuploidy is strongly recommended in these kind of genotypes. If there are IL-10 and IL-21 genotypes identified, then there is an anti-inflammatory therapy and there is no aneuploidy risk. So a routine double marker or whatever that is done can be advised. In cases of high oxidative stress, there is an antioxidant vitamin E and C that will be advised. This is basically an evidence-based treatment, and this is purely case-based. Like, for each individual patient, the treatment and of course the genotypes and all will differ, and accordingly the treatment also will be done. That is the pharmacogenomic implications that we are going to talk about in such cases. Now, consanguinity is one of the most common things that we South Indians come to see in our daily practice. First, we look at genetic disorders. We know that this is chromosomal karyotyping, copy number variation, cytomegalomy. The Mendelian single gene disorders are inherited as dominant or recessive or X-linked. In dominant, we all know that if there is an unaffected parent, then there is a 50% recurrence risk in every pregnancy. Suppose in one of the pregnancies, we see that the fetus has something like achondroplasia. We know that it is an autosomal dominant condition and the recurrence risk will be very low. But if the parent has a kind of an autosomal dominant condition, then we know that there is 50% recurrence risk in every pregnancy. Whereas in recessive condition, we know this is something which is commonly seen in consanguinity, where the parents are both unaffected carriers of the same mutation or a compound heterozygote mutation, and there is 25% recurrence risk in every pregnancy to have an affected fetus, and 50% of having a fetus which is a carrier and which is as normal as the parent, or a 25% risk for having a normal fetus. Whereas an X-linked recessive, where the mother is the carrier, then there is 50% risk in every pregnancy. The male child is affected, and the female will be the carrier. Now, in consanguinity, the risk is high because the genetic material that is shared between the first cousins is around 1/8. The chances that the cousins share the common recessive mutations increases, and there is a 25% recurrence risk in every pregnancy. That's the reason why we suggest extended carrier screening, which can identify risk for multiple disorders apart from common. See, there are common disorders like spinal muscular atrophy. This is not covered under extended carrier screening, because extended carrier screening is done under next generation sequencing, that is an exome sequencing. So in that, you cannot identify conditions where there are deletions. For that, we do a different technique called MLPA. That also will be covered along with this. Like when we suggest patient, we say, please go for an extended carrier screening and SMA testing also. SMA is the spinal muscular atrophy is one of the common recessive disorders that is seen in Indians, more so among a consanguineous couple. Now, this extended carrier screening can be suggested as a premarital or a preconception, or in the early pregnancy, or in cases where they have history of one child with a genetic disorder or a neonatal demise. Of course, because of the extended carrier screening, there is an option of pre-implantation genetics also along with prenatal. Now, these are the two cases that we'll show you where there is how the carrier screening has helped them. This is a non-consanguineous couple. 2 male pregnancies were terminated because of hydrocephalus. The female partner was identified with an L1CAM gene, which is a hemizygous. That means she is carrier for that X-linked hydrocephalus. So there is a 50% risk for every male offspring and in every pregnancy, and an amniocensus was offered. Whenever there was an absence of the mutation, then only they could continue the pregnancy and deliver a healthy baby. In this couple, there is a consanguineous couple. There was a 3-year-old male child with hydrocephalus demise, and then the parents had come to us. So we had to do an extended carrier screening. Had we done this in the male child, it would have been much more easier. But because of course, they did not do it, and their consanguinity, we wanted to check for all the autosomal risk for autosomal recessive disorders, and we did a extended carrier screening, and they found that they both are carriers for this particular CCD-C88C gene, and they are that causes autosomal recessive hydrocephaly type 1. Since there is a 25% risk in offspring, same mutation testing was offered, and the prenatal, and then the baby, they have delivered a healthy baby. So in cases where the child, the proband is available, we would like to test the proband. But in cases where there is no proband available, then in such scenarios, we would suggest a carrier screening for the couple. Spinal muscular atrophy, as I told you, this is done by an MLPA technique where there is a deletion of these genes, commonly SMN1 and SMN2 genes. And then once this is confirms that there is a homozygous deletion in the proband, as this is done, it was a 7-year-old child, then it was understood that this is the particular deletion in the child that has caused SMA. So every pregnancy, there was a prenatal was offered, and confirmation of that particular deletion was done, and then of course they delivered a healthy baby. Beta thalassemia, again a common hematological disorder that we see in Indians, more so in consanguineous couple. HBB is the full gene, that is HBB gene is the one, the causative, where we do a HBB full gene sequencing. And in this particular case, we have identified the child with this homozygous codon, and then this is confirmed again in the parents. And after that, once it is confirmed, and 25% risk of recurrence and a prenatal diagnosis was offered. Child with hearing loss. Now, hearing loss hearing loss can be syndromic or non-syndromic when it comes to genetic part of it. Now, non-syndrome, in the syndromic part of it, we don't simply do a exome sequencing, we do a cytomicroarray. This is to rule out if there are any deletions or duplications. For every syndromic presentation of hearing loss, we first do a cytomicroarray, but whereas a non-syndromic hearing loss, we always do a exome sequencing to rule out whether it is a recessive, dominant, or an X-linked hearing loss. Based on that, further testing can be offered. If in the syndromic hearing loss, we find in the cytomicroarray, if we find out that there is a pathogenic mutation that is identified, then based on that, if it is a dominant, then the recurrence risk is low. Then if it is recessive, then testing in the parents, all this will happen. Duchenne muscular dystrophy is again a MLPA technique where the mother is the carrier for it and the male child is affected. In this case, the female partner lost her brother around 22 years, and since there was no testing done, we had to do testing in the carrier testing in the female partner, and we found that the dystrophin gene, there is a heterozygous deletion on that. And then since there is 50% risk, prenatal was offered, and then that showed an affected fetus with DMD, and they had to terminate. Now, these days, most common complaint that we see among with pediatricians and thing is autism. Autism, of course, can be genetic and non-genetic. In autism, the first thing that we see, first test that we do is cytomicroarray, because we want to rule out if there are any CNVs. In this particular case, this is a 3-year-old with ASD and ADHD. We did a cytomicroarray, and we found a pathogenic deletion in 2q23, but the recurrence risk is very low. So for the further pregnancies, they don't have to get the tested. But in case if they're very anxious and they want to, then we're not, we can offer them, but ideally there is no need to go for an invasive testing. In cases where there is a cytomicroarray is normal, then an exome sequencing is offered. In this particular case, similar case, autism spectrum disorder, ADHD, cytomicroarray came normal, then an exome sequencing was offered. A recessive mutation was identified, and the parents are carriers for this. In such cases, of course, if they go for an IVF, a PGT option can also be discussed. This is something I need not discuss because both the doctors have already discussed about it. NIPT as a cell-free DNA testing. NIPT can be done as a primary screening or secondary screening. NIPT as primary screening is generally commonly seen in cases where there are IVF, where there are precious pregnancies. Doctors are opting for NIPT as a primary screening. Of course, in high-risk cases, you can go ahead with an amniocensus or a CVS, and then normal, there is no issue, you can routine follow. But if it's a confirmed aneuploidy, then medical options if the amniocensus is confirming it. Any high risk in NIPT has to be confirmed with amniocentesis. Now, pre-implantation genetic testing is something I would like to just brief upon. Pre-implantation genetic, there are 4 types. First is PGTA. PGTA is only looking at aneuploidy risk. It is if they are going for an IVF, then this particular PGTA is offered because of the age or because of the IVF risk. It's of course a sporadic or random risk because the parents would have been normal and they transfer only the euploid embryos. There is another test. Instead of doing the taking out biopsying the cell of the embryo, they do from the spent media, the DNA fragments in the culture media. This has a lower sensitivity than PGTA, but it of course rules out aneuploidy risk. This NICS can be used only for aneuploidy risk, cannot be used for other kind of PGT tests. Like, see, if the parents are carriers for a translocation, one of the parent, then you cannot use NICS. Then you use PGT-SR, where we are looking at the structural changes. Okay, in PGT-M, if the parents are carriers for some kind of a Mendelian disorder and there is a mutation that is identified, then we offer PGT-M. But please note that it has to be done. It can be offered for parents with only one single mutation. If there are a couple who are identified with multiple mutations, this testing could be little difficult. And always remember that PGT-M cannot be offered. There has to be a pre-workup that has to be done, and then only it can be offered. Now, coming to sample collection, of course, karyotyping is done in sodium heparin. For all DNA testing is EDTA tube. Most importantly, for all EDTA, for all prenatal testings, like where amniotic fluid or CVS is collected, or for that matter, POC is collected for a cytomicroarray or any exome sequencing DNA testing, then 3 ml of mother's blood has to be collected in EDTA, that is to rule out a maternal cell contamination. Of course, if there is an embryo, then there is an embryo biopsy kit that has to be given. Now, our forte is basically in genetic counseling. We do a 3-generation pedigree. We do the studying of all the medical records, proband examination, a detailed phenotype will be taken, and then after the testing is done and the results are there, we give them a clear prognosis and a recurrence risk. And of course, we are also recommending the correct test, and we are writing it down in a clear letter and calling the physician and informing that this is what is being advised to the patient, and the patient has opted for this test. And most importantly, after the test is done, the results are also clearly discussed with the physician. Thank you.
Wow.
Yeah,
Dr. Malini, your comments? Yeah.
Yeah, thank you, Dr. Vinata. This was a very clean and clear presentation as to what are the tests that are available for the obstetricians, especially in the internal medicine or obstetric practice, and also in dealing with the whenever we get a child with autism, and where we can use them, the various tests like KT, CMA, sequencing, MLPAs, and all. And he also very clearly explained about the importance of testing the proband. And here comes the concept of DNA storage when we are not able to, or when the couple is not able to, decide about the amount of testing or how much they want to test. So DNA storage would be a good option for them. And you also elaborated about the sample collection. This is where we usually get confused. In what sample do we take? Do we take mother's blood as well? That you have brought up on very neatly. And also the importance of pre-test and post-test counseling, not just send for an IPT. The couple should understand the implications of an IPT. What if there is a no call? What should be done further? So all these should be explained in a pre-test and also as well as a post-test counseling. Thank you for bringing this out very clearly. So we will take any questions if they are there in the chat box or any questions addressed personally to the speakers.
So there is one remark by Dr. Lakshmi that NT scan there was anencephaly diagnosed. Yes, indeed, Dr. Lakshmi, NT scan can diagnose anencephaly anytime after 10 weeks. If there is absent fetal skull, it is diagnostic of anencephaly. Next, Suman madam is asking a very practical question. How many days after the NT scan can we go for double marker test?
How many days?
Yes, ma'am. So some patients don't, even when instructed to go for double marker on the same day, they'll just delay it. Maybe they'll go after 3-4 days, 1 week. Is that fine, or what would you advise?
Yes, that's okay. NT scan the blood can be collected till 13 weeks and 6 days, but not beyond.
Okay, ma'am, but the CRL value will be important for the calculation of MOMs of...
You do not need the CRL value. You only need confirmation that dating is correct.
Okay.
Dating could have been done at any time. It's only we should know that the dating is correct. You do it on the same day only for convenience purpose. Patient comes to your clinic for a scan, and the blood is collected at the same time. Ideal would be to ask them to give the sample at 10 weeks or 10.5 weeks. But the thing is, sometimes there may be a miscarriage. You don't know about it. Patient has to have a second, has to go to the lab and then come to you. So for practical purposes, it is done like this. But if you can give the blood sample for the test at 10.5 weeks and do the scan at 12.5, that is the best detection rate. That's all. So you could collect the sample of blood anytime up to 13 weeks and 6 days. After 13 weeks, after that, if you do, they'll do a second trimester screening.
Okay.
That was such a wonderful presentation by all the faculty members. I'm so extremely grateful for having taken the call to be present for this webinar on such a elaborate talks, and having dedicated the Sunday afternoon. I'm sure the entire week would be busy for all of you, but still you could sacrifice the 4 hours time for this dedicated webinar, and any amount of discussion or talk still seems to leave behind some doubts, and there is a long way ahead, and the past 1.5 decade have helped us to quite well understand the intricacies of this problems that we are coming with. And Vinuta, that was such a masterly presentation, so well simplified and brought up, and just what we had asked for is what you have delivered. And I'm sure most of the viewers who are here, the delegates, about 60 of them are still logged on. There were more than 100 people who had logged in on this Sunday afternoon. Still 60 of them are around, and I'm extremely grateful that all of you, our patron, Dr. M.G. Hiramat sir, Dr. Kasturi Dhonimat madam, Dr. Bharti Rashekar madam, Dr. Asrana Durgadas sir, and the past president, Dr. H. Nagraj sir, he sent a message to me on the WhatsApp that it's a very nice presentation going on. And there are very many seniors in the faculty who have logged in on this Sunday afternoon and been present all through the deliberations. Extremely grateful to our very elite and knowledgeable members who have delivered just what the doubts were and the queries were. Dr. Chitra Ganesh ma'am, Dr. Preeti Venkatesh ma'am, Dr. Malini, Dr. Vinita, Dr. Milinsha sir, and Dr. Navya. such a wonderful presentation. It's been very delightful to be listening to all of you. Extremely grateful to all the delegates who have logged in. And I'm sure you have been benefited by this wonderful presentations. And we are looking forward to more such sessions. And very soon we'll get back with much more fresh practical topics and let you know very soon the date as to when it's going to be. We would like to have a feedback whether the Sunday afternoons are convenient for all of us, because our faculty are very busy on the weekdays and Sunday. They have sacrificed their family time and their relaxing time and their leisure time to be able to spread more knowledge and reach out and percolate to more members in the society. And believe me, there are members even from Bihar, Patna, who have logged in into this session. So Zoom meetings are a blessing in disguise that anybody from anywhere can take the benefit and advantage of learning if they want to learn. And what we are is because of genes, and thankful that we have all inherited good genes, and we know when to refer the patients whenever they're having a problem, to sort out if there is any help we can give for them in terms of genetic testing and screening. Much more things need to be evaluated in terms of genetic screening, because not one test is good for all, and being able to decipher what is needed for each one of them is the crux of the matter. Extremely grateful to all the members and to Shield Chitrakala for having coordinated with us so very well and helped us to make the flyer, helped us to design the program, and seamlessly having transmitted the webinars. I think there was no technical glitch at any point of time so far as the relay was concerned. And thankful to all of you. Have a very great evening. Thanks to Navya, who has been there very enthusiastically, being able to coordinate with the programs and communicate with all of us, and having brought us together in all her communications. I'm sure we will be looking forward to more such interactive sessions. Extremely thankful from my bottom of